extends a warm and a sincere welcome to our esteemed dignitaries, respected principals, and the distinguished guests who have gathered here today. We are pleased to host this essential workshop on competency-based education in allied and healthcare professions and implementation strategies. The central objective of this workshop is to precisely equip our institutions to facilitate a dynamic process of learning, unlearning, and relearning, thereby ensuring the highest standards of academic growth and excellence in healthcare education. Before we officially commence the program and introduce our distinguished resource speaker, please allow me to draw your attention to a brief yet vital guideline to ensure a productive and focused session. We kindly request that all mobile phones and electronic devices to be set to a silent or vibrating mode. This will ensure minimal disruption to the speaker and your colleagues. Your perspective remains vital for the continuous enhancement and refinement of our educational programs. The QR code to the feedback form will be shared at the end of the workshop, and we deeply appreciate you taking a few moments of your time to complete it. We thank you for all your cooperation and look forward to a successful and an insightful workshop. I take this moment to welcome our first speaker for this workshop, Dr. G. Arunmaya. Sir is a distinguished academician, administrator, and a prolific researcher, currently serving as a professor of physiotherapy and dean of Manipal College of Health Professions, Manipal Academy of Higher Education, Manipal. The administrative and leadership impact of Dr. Maya is far-reaching. He holds the esteemed position of President of the Autonomous Board of UG Education for the Karnataka State Allied and Healthcare Council. Sir is also the Principal Coordinator for MIDAS, the crucial DST Mahe Medical Device Hub, driving innovation at Mahe deemed to be University and Institute of Eminence, Manipal. Internationally, Dr. Maya contributes as a visiting professor at the Laser Research Center, Faculty of Health Sciences, University of Johannesburg, South Africa, and is also the director of Maya's Healthcare Innovation Private Limited. Dr. Maya is globally recognized for his pioneering research in cardiopulmonary rehabilitation and diabetic foot care. He leads the Center for Podiatry and Diabetic Foot Care and Research as its chief, cementing his role as a clinical expert. His influence extends to professional bodies, where he serves as the president of the Indian Podiatry Association Karnataka chapter and the membership director of the World Association of Photobiomodulation Therapy. A testament to his inventive spirit, Dr. Maya holds several patents and copyrights for novel biomedical devices, including the design and development of laser shoe in diabetic peripheral neuropathy and a pain-relieving instrument. His academic output is profound, with over 305 publications in reputed national and international journals. His work is highly cited with an impressive H index of 36 and over 6,300 citations. He has successfully attracted numerous national and international grants, heading 16 major projects, and has played a pivotal role in shaping the next generation of researchers by successfully supervising over 26 PhD students. Dr. Maya also contributes to national policy as a member of the Expert Advisory Group for the Biomedical Device and Technology Development Program under the Department of Science and Technology, Government of India. Please join me in welcoming a leader, an administrator, academician, and a researcher in health sciences, Dr. G. Arunmaya. This session is focused on evolution from traditional to competency-based learning, understanding the core concepts like the competencies, learning outcomes, and performance indicators, including global and national perspectives as per the NCAHP guidelines. We welcome you, sir.
Thank you. Very good morning to all of you. Today will be actually one of the toughest day I can call, because teaching the teachers will be a hard task. Because all of you are very well reputed academician, researcher in the various disciplines of allied and healthcare profession. Therefore, as I mentioned, it's a challenging for us to interact or the addressing all of you. However, we will try our level best to ensure that whatever the implementation strategies have been highlighted by the National Commission for Allied and Healthcare Profession will be addressed today. And maybe a quick overview, many of the faculty may not aware, the Karnataka State Allied and Healthcare Profession Commission is established in 2024 under the leadership of Dr. U.T. Iftikhar sir as a chairman, myself as the president for the undergraduate board, Madam Sunita as a president for the postgraduate board, and then also Dr. Praveen from Bangalore as the assessment and rating board, and then Dr. Archana as the ethics, and with Dr. Anita as a chairperson of the ethics. And we have members from the various disciplines of the allied health professions in that commission, and I can very confidently I can share that this is the one state council is progressive and try to implement whatever the policies have been defined and approved and released by the National Commission in the larger benefit of the healthcare students as well as the professionals. In that aspect, the series of meetings have been conducted in the last 1 year, and 29th July we had the first workshop. Before that we had one common workshop at the Rajiv Gandhi University, that is basically to plan how exactly this curriculum can be implemented successfully from the 2026 admission batch onwards. Then subsequently one more workshop we had at Bangalore in Ramaya University, organized by Savita Madam. There we exclusively focused on the what all the programs have been released, what all the implement strategies, and as the outcome of that first meeting, the committee of the commission also decided that we will conduct multiple workshops to the teachers across the state. Thereby every institutions, every university will be trying to implement the curriculum as per the recommendation of the commission. So this is the second workshop, and then 6 zones have been divided at the state, and different workshops will be conducted in the different part of the state. And also thanks for our alumni. She is our alumni, and when our alumni are introducing us, we'll be very happy because they add more information to our profile. Thank you for your nice introduction. Maybe a few slides I just wanted to highlight about the background of today's discussion. As I mentioned, the National Commission for Allied and Healthcare Profession is established in 2021 under the Ministry of Health and Family Welfare, Government of India. And 13 recognized professional domains have been listed, and it includes more than 56 subdomains. I request all of you to go through these documents, which is available in the public domain. It is important for all of us to understand the policies, the guidelines, the various recommendations given by the Commission in the larger interest of our future students. The next important thing is the committee also decided that one nation, one curriculum. This is more challenging because as of now, in the absence of the regulatory body from the last many years, many professionals like examples like physiotherapy may be started almost 55 to 60 years back. Like that, the other professions have already started from last 20 to 30 years. Every university had different curriculum, and we had a different teaching, learning, evaluation process, and also the various clinical or the academic teaching process. But with the introduction of the one curriculum, it's our responsibility to implement this curriculum across the country, and we need to ensure that the students will be trained in the same fashion, irrespective of the university, irrespective of the state where they are enrolling to the programs. Then the next important thing is all the existing diploma programs will be phased out over a period of next 5 years. Then this is the important changes recommended by the Commission. In addition, there are few circulars recently have been, this is an updated informations. The Commission also recommended another 3 important programs to be executed from 2026. In July, when we discussed in Bangalore, we had a 10 program. Now it becomes 13. Then maybe another 2 also in the public domain. As mentioned by the chairperson of the National Commission, at least the 16 curriculum they want to implement across the country from 2026 admission onwards. And another important aspect also, the government have suggested that to ensure the minimum eligibility criteria of the students to this program, the NEET appeared is one of the guidelines recommended by the Ministry of Health and Family Welfare. It is not necessary that they need to wait for the NEET score. So sometimes it is, we see in the social media and all that the NEET is compulsory, NEET score is compulsory. It is not necessary that the student needs to have the NEET ranking. NEET appeared the purpose of the Commission to ensure that the students with the 10+2 in science will be enrolling to this program. What they observed in the few universities earlier, the students have been enrolled with the different background. So since it is all our healthcare professional programs, the science background is one of the minimum criteria. Therefore, the NEET appeared is recommended by the Commission. So this is the just updated information recently circulated from the central as well as the state commission. And another important aspect is the state commission is communicating to all university. It may not come to the each institution separately, but we have a public university like Rajiv Gandhi University, we have the deemed to be university, then we have the state private university. All these university registrars are getting the communication, and subsequently that is disseminated to the institutions and to the faculty. As I mentioned, this is the Karnataka government notifications to establish the state commission. So with this background, why it is important that all of us needs to meet here and discuss about the implementation. And competency is a important the aspect given by the Commission, because all, as I mentioned, we are all the integral part of the healthcare system. The knowledge and the skill, the student needs to have an equal knowledge and the equal skill. For that, when we are teaching the students, it is important that how a curriculum, we should address the knowledge component, maybe like a theoretical aspect. Competency or the skill component, how it need to be included. Therefore, it is designed to produce a globally competent allied and healthcare professionals to address the increasing prevalence of disease and the growing demand of the allied health services. If you look at the 2016's World Health Organization statistics, by 2030, almost 60% of the healthcare force will be, I call it as a supported or maybe controlled or maybe an important member in the healthcare system by the allied and healthcare professionals. That is, the demand is there both at the country as well as at the global level. So the objective should be more focus on the standardization, because when the candidate come out from any institution, they need to have the basic or the minimum skill and the knowledge component need to be there. And according to the other universities, the progressive thinking, when you think progressively, there is always Commission have given the scope that at least 20 to 25% of the syllabi recommended by the Commission can be modified, not modified, it can be added in the larger interest of the student. Therefore, this is the minimum standard curriculum. The additional thing which is essential as part of the present need of the healthcare system, the university can include those, the component in their training program. The next important thing is the competency-based approach. Then the holistic development. When this is another important recommendations by the new education policy. Some component of the new education policy is also included when the curriculum is recommended, because the professionals, the training, the student training needs to be an holistic approach. When they come out as a professional, they need to be ready to face the challenges, multiple challenges in the society or in the healthcare system. And next is the support for the universal health coverage. This is what I mentioned about the 13 different professional domains have been released by the Central Commission. If you look at in each one, there are subdomains are there. Except the physiotherapy and the occupation therapy have the independent professional practice or the independent profession, but in all other things, there are different subdomains have been added. Medical and the medical laboratory and the life science have 11 subdomains. Trauma care, surgical and the anesthesia related technology have 6 subdomains. Physiotherapy 1 independent domain. Nutritional science professionals have the 2 different subdomains. Ophthalmic science have 3 different subdomains. Occupation therapy once again independent thing. Community care, behavioral health science have 14 subdomains. Medical radiology, imaging, therapeutic technology professionals have 5 subdomains. And medical technologies and physician associate 9 subdomain, and the health information management, health informatics have 4 subdomain. In the phased manner, the curriculum will be released by the National Commission. As I said, now the almost 13 have been already released. Another 2 are in the public domain for the input from the public. Maybe the 15 will be, as informed, will be implemented from this 2026 admissions. This all the 15 professionals body. Recently, the occupation therapy, medical laboratory science, emergency medical, and then nuclear medicine technology, and the medical and the psychiatric social workers domains these curriculum is in the public domain also. So why today, what is the purpose of for us to discussing the outcome based or the CBE? There is a slight difference in these 2 aspects, but when we look at all these 15 curriculums, the both are the overlapping. Therefore, some of the components of these 2 have been we combined in our today's discussions or the presentations. The first important thing is national shift towards the outcome driven training. So when we are training any of the graduates, the purpose or the scope of practice needs to be very clear. As a graduate student, what is their graduate attributes or what they need to know. When they become specialized, either with the masters or with the higher degree, what will be their scope of practice. This is the one important aspect needs to be clearly defined in the curriculum, and then also we need to sensitize students. Standardizations and accountability in allied health. As of now, the many colleges have been started, but unless the regulator comes into the picture, the professional body or the professional community will not be regulated in the country, because there will be a lot of cross practice, there will be a lot of malpractice, there will be a lot of quack practice. This all can happen because there are no regulators. Now, maybe we are very happy to say that with the with the establishment of commission in the near future, so these things will be definitely regulated by the commission. Aligned with the National Commission for Allied and Healthcare Professions requirement, improving the graduate readiness and the patient safety. So the graduate readiness, because the science is very dynamic, every day it is growing. A lot of changes are there. We call it the yesterday's curriculum, today's teacher will be teaching for the tomorrow's student. That should not happen, because that needs to be dynamic, where what will be in the next 4 years when the students comes out as a graduate, what is the minimum expectation from that particular graduate. Therefore, a teacher-centered learning is shifted to the student-centered learning. Most of the time in the earlier, if you look at the things, most of the things we teach, we say that we are taking this many 40 hours of class, 50 hours of class, 60 hours of class. Whether the student is digesting that, we don't know. Therefore, here, when in all the higher educations, When the competency-based education is introduced, maybe Shivshankar sir is here, he maybe agree with me, in the medical college, also when you introduce the competency-based education, the students, these three aspects needs to be important in terms of knowledge, in terms of skill, in terms of attitude. And equal participation from the student is important. Then only the student we will be able to train them properly. Therefore, a teacher-centered learning, it needs to be shifted to the student-centered learning. These are all the three important things. Even in the advanced digitalization, with the introductions of the artificial intelligence and other advanced technology, but in healthcare system, these all going to become a complementing. They are not going to shift, change or replace us. Therefore, with the introduction or with the updated technology-oriented training, these three qualities needs to be always inculcate in our student. First important thing is the soft skill. This is the most important challenge. The recruiters, they tell, student may be having the knowledge, but the student is not able to communicate effectively. They are not become their integral part of the system. Because this soft skill, what should be their professional ethics, professional the behavior, attitude, these things are actually given a lot of importance in the training, the core expertise and the high quality patient care. So this is the important thing, like from the traditionals to the outcome based or the competency based education, knowledge to performance, teacher centered to learner centered, time based to mastery based, and the summative examination to the continuous assessment. In my presentation I am giving only a quick overview, then subsequently all other speakers will, in each particular sessions, they will go in depth about how exactly the competency component can be incorporated in the curriculum. The last point is important because rather than assessing them at the end of the year, this becomes day also 3 hours of examination, student will by heart, student will come and then on the day of exam they reproduce and then go. That should not happen. When we say the competency based assessment, continuous assessment also needs to be given equal importance. But in the present curriculum, it's only in the range of 70 to 30 or 80 to 20. Normally, if you look at in the very established or the other Western universities and all, they are giving equal importance to the continuous as well as the end term evaluation. That is called 50-50. That is very, very, very important. Even in the recently ICT for the engineering students or other curriculum, they have suggested that 50-50 component. 50 should be at the end of the semester or the year we have to evaluate, and the 50% of that needs to be an integral part of the day-to-day learning, so that, as I mentioned, the knowledge, the skill, attitude component of the student will be improved. And standardizing the clinical training is important, because this is a few points we are repeating, because the skill component is very, very important. Therefore, the quality training of the students in the clinical clinical area is very, very important. Structured logbook and the documentation. Faculty training is very important. Today we are working on this aspect, quality assurance and the compliance audit. So if you look at this, is the why it's important, the student-centered learning is, when we were all studied in 1980s, 1990, we were all the millennium batch, because in that time we studied. That time it was more of the teacher-oriented thing. Then we go to the library. Then we call it centennial, 2000 to 2012 batch. There a small amount of the technology component have come into the picture. If you start from 2012 to 2025, usually you call them the alpha generation, where they are all tech-oriented people. So if whatever we are teaching today, they may be already searched in the Google or somewhere. It's every resources are readily available. Therefore, the student engagement is very, very important. This point I want to stress again. The student engagement in the day-to-day learning important. If you teach and then go, there is no use. So that, and another important thing is, as I said, technology savvy. preferred collaborative learning, prefer free expression, prefer autonomy, innovative and creative, and short attention span. This is what you can see in the young generation students. The collaborative learning is a very, very important. Interdisciplinary learning is very, very important. And last, the attention span. This is not the very well documented thing, because one of our own senior teachers told us earlier 45 minutes of class means our attention span used to be in a span of 25 to 26 minutes. After that, another 15 minutes, whatever teacher taught, it is go out of our thing, because that was now the attention span is only a 6 to 8 minutes. If you take 1 hour class, attention span is only 6 to 8 minutes. This is one of the senior teacher have done the survey, and they are suggesting that because they are tech savvy, they get, when today you may be giving one topic, they have already getting that information in that. They are not giving much importance to what we are teaching in the classroom. Therefore, innovative, and they are innovative and creative. Our student, that we have to, how to include them in a integral part of the day-to-day learning should be our thing. And another important aspect is any regulator will release the curriculum, and it is called the one curriculum, as we said. The syllabi component is the university or the institution's responsibility. This is the difference between the curriculum and the syllabus. It is a set of course an educational institutions offers as per the recommendation of the commission. Whereas here, when we syllabi, descriptive list of subject to be taught in the class every semester, every year. Now we may be today onwards we will call it as a program and the course. We will not call it as the syllabi or the subject, because it's a program is a like bachelor of any of the particular program. Then the course will be the individual, the course in the different semester or in the year. So the most important thing is it can be adjusted per class requirement. So there is a 10 hours of this. I will give the example a little later. If there is a 10 hours is defined in the curriculum, the teacher can define, if it is a theory thing, how much the teacher can teach, how much the student needs to be involved, how much needs to be given for a small group discussion. That planning flexibility is there to the respective teacher. That is one important difference between the curriculum or the syllabi. So when we say the competency-based education, it's a structured educational approach. Progression is based on the demonstrated competency, not the time spent. Therefore, especially in the technology, some of the programs are significantly, they come to lower number of hours of training. The component is called now micro-credential. I think all of you are familiar with that. This is what the industry need. I'm not talking about the healthcare sector, just giving an example in the engineering side, the micro-credential, because they want that skill set. Therefore, not the spending 4 years or 3 years of thing. They give, even if one individual have a micro-credential of this particular skill set, if it is meeting the requirement of that industry, they take them. But in a healthcare system, the method is slightly different, but where we need to have a clear, because there are specific duration of the program that we cannot able to violate, it is as per the recommendations of the regulators. But we need to have a clearly defined competencies, should be defined for each course. Each course can be further divided into the unit. The unit can be further divided into the lesson plan. That needs to be in that format. Actually, we need to deliver. Maybe with one example in the second talk, I will be highlighting that real life performance, continuous feedback in the assessment. As I said, the focus is on the outcome, and most important thing is the student lecturer's engagement needs to be more strong. Means everything you need to teach, you can assign to the students and ensure that the student is completing those specific components as per the timeline defined by the teacher. And students are equally responsible for their own learning. This is what in any competency-based education, these components are highlighted. And this component also subsequently maybe Sunita madam or Dr. Senthil or other team will be highlighting on this. So this is based on the Bloom's taxonomy. When you look at the domains of the learning, the cognitive or affective or the psychomotor. So accordingly, we define it as knowledge, attitude or the skill. Components are addressed in that. When you take the theory class, it focuses more on the cognitive skill. The student may be remembering, may be understanding, they are ready to recall. And whereas when you look at the clinical component, clinical testing, examples may be a simple clinical test, a simple clinical evaluation, that have the strong psychomotor component where students should be able to reproduce that in the real time situation. Okay, this is the important terminologies have been defined by the curriculum. When you go through the curriculum, all these points are well addressed. Every program have a clear vision and mission. Program educational objectives are there. Program outcomes, course outcome, learning outcome, students learning time, graduate attributes. This is at the end of the 4 years or 5 years of training. What should be the minimum skill a student needs to have, whether they are ready to face the society. Assessment and the program monitoring and evaluation. So this component, as I mentioned in the beginning, we are interacting with the teachers. This maybe you are already been practicing in your system. So this is an opportunity for you to relearn. It may be a few of the faculty members. So it is a new learning to all of you. So that these details will be highlighted and discussed in the subsequent sessions. Focus, as I said, structured approach for continuous improvement of the teaching learning process. And all the regulator, all the accrediting body always encourage a 20% of revisions periodically. If you look at the National Assessment and Accreditation Council, it's an accrediting body. Usually they expect that a minor revisions can happen every year or in every board. That is usually we call less than 20% of the changes. That flexibility is there. Even if you go through the national guidelines or the documents of the commission, this flexibility is given to the state or to the university. Within the 20%, the changes are permissible. And usually after the one cycle of the completion of that particular program curriculum, then needs to go for the major revision. That is 20% and above. According to the duration of the program, if it's a 4-year program, after the 4 year, there is again provision for the universities or the regulators to revise the curriculum. Whereas less than 20%, every board of studies or every year, according to the need, the university or the autonomous institutions have the flexibility. So this is when you say the competencies in the allied health, these all the important component needs to be highlighted in the course. One is the clinical examination skill, patient-centered communication, interprofessional collaboration, because they are the integral part of the healthcare system, ethical practice, and then the safe and effective clinical procedures. Whatever they are doing, they should be able to do it properly. Then the next important aspect is the learning outcome. Describe what the learner will be able to perform. Means when you are taking, as I said, the syllabi into the unit, into the lesson plan, in that you can have the specific, the theory as well as the practical component. Examples like when you say demonstrate safe patient transfer techniques independently. I'm just giving it may be applicable to many of the students. Maybe somebody in the hospital, in the public, when you see a road traffic accident happens. I'm just giving an example. This is a basic skill as all healthcare professionals we need to know. We don't know whether they had a cervical spine injury, whether they may be having the rib fracture, they may be having the fractures of the spine. We don't know that. So if a layman, what they will do? They will make the patient sit and then give the water. This is commonly happens. By the time if there is a fracture, a hairline fracture must have become the displaced fracture. It can worsen the thing. I'm just giving, this is a simple thing. A safe, when you say the safe transfer, Patient safety is very, very important. This component needs to be highlighted to the student. I'm just giving the simple thing. Use proper biomechanics. How if a patient may be an 100 kg weight, what should be the strategy by which they can shift? Communicates instructions clearly to the patient or party, or if you are addressing with the other healthcare systems, and ensure the environmental safety. These all the usually the program outcomes. Normally in the healthcare we have 12. In engineering and technology usually they have the 12 outcomes, but in healthcare is usually up to 8 is acceptable as per the Bloom's taxonomy or from the based on the outcome based thing. This all the different program outcomes, like starting from professional knowledge, clinical or the technical skill, teamwork, ethical values and the professionalism, communication, evidence-based practice, lifelong learning, and the entrepreneurship, leadership, and the mentorship. This also will be discussed in detail little later with the what is the attribute, what is the competency in each one, what should be the thing we need to deliver to the student. Then once again we have a program educational objectives. This is the at the end of the course, what is the graduate attributes, whether what all the skill or the attributes the students have trained. This all have been defined in the scope of practice of each curriculum. I am not going into the details of that. The last important component is assessment can be in OSCE or OSPE, mini clinical evaluation exercise, direct observations of procedural skill, case-based discussion, reflective portfolios, and the skill log books. So this, once in the subsequent sessions we will be discussing each one separately. And then the assessment component also can be divided into two, formative and the summative assessment. As I said, everything no need to assess only in your internal examination or at the end of year examinations or the end semester examination. This can be assessed in every unit. Once you complete one particular unit, the students can be evaluated. That can become the part of their internal assessment. Most of the time we take the average of the 2 or 3 internal assessment and we are adding that to the university paper. That students may be performing good, may not be doing well during those internal assessment. We cannot judge the student by 3 hours or by 1 hour. Therefore, the continuous assessment component is very, very important. In all the things, if the student is not doing well, we don't have any thing that, but some students, due to some various reasons, they may not able to perform very well in the 3 hours of examination or at the end of the practical exam. We cannot decide their future just by the 3 hours. Therefore, a simple continuous assessment in terms of various methods by which we can assess the students throughout the year. One example I wanted to give here, the teaching learning strategy. Suppose if you are in the first year, if you have the unit have 15 hours of training, how exactly it can be given? This is what in most of the credit based the developed or the European or the US, they practice this method of training. You can divide into 3 different segments. 10 hours of teaching maybe by the faculty. The 30 hours the student needs to spend on that, like in the form of assignment, in the form of any other method by which you ask the student to prepare and then they have to submit to the that individual teacher. Then you can also include, rather than teaching all 15 hours by faculty, include small group discussions where the active learning process, the student needs to perform that. And the self-directed learning can be also given to the student. So in principle, if we teach 15 hours, ideally the student needs to spend 3 times the whatever is taught by the teachers. This is what, it is not only in the classroom, it is out of the classrooms, library hours, so many other methods by which they also need to be actually participated. Okay, this maybe will link. So what is the implication? This overview of our competency-based education to all the senior academicians and the leaders we all gathered here. First important thing is lead curriculum alignment and redesign. Because as I mentioned in the beginning, we all of us have a different curriculum. The 2026 onwards, all of us needs to have one curriculum. The reason is, in future, students, if they wants to go to abroad, their credentials evaluations is in aspect will be certified by the commission. As of now, sometimes they write to the professional body, or sometimes they directly write to the university. We endorse the students' thing. But in future, when the commission is controlling or registration process is done by the commission, this even the cross verification of the students' learning outcome is also taken care by the National Commission. Therefore, our 2026 onwards, realigning or redesigning as per the curriculum of the National Commission is important. Build faculty capability, because change will not happen in a day. It will be challenging, all of us, it will be challenging. It is not so easy that the National Commission have released the thing, start teaching. No, it is practically not possible. So as a team, it is because most today's discussions, we have invited only the principals or the senior faculty. We request you take the lead at your institutions or the department, ensure that other faculties are also aligned with you so that implementations will be more strong. Strengthen the assessment system. As I said, rather than assessing them at the end, include in every unit, give equal importance to the students' engagement, students' participation. Ensure clinical exposures and the simulation resources. In the first year, if there are facility, some of the component can be with the simulation learning they can do. Then subsequently, when they go, they get a real-time exposure. Institutionalize monitoring and evaluation process. So competency-based education is not just a curriculum change. It is a culture change. So today or the 2026 onwards, the academic process of the allied and healthcare professional course across the country will have a, like as we said, one nation, one curriculum, so that we all need to be ready to accept that and then start implementing it. Education leadership is key to successful implementation, because our commitment, the accountability, our involvement is very, very important. With this, I conclude my introductory sessions now. Thank you all. Maybe we will have the subsequent in the next, after 1 or 2 sessions, with one example, because the most important discussions today, what we are going to do, will be highlighting on the first year course, because that is the challenge. In some maybe we have an independent institution, in some we have 5-6 programs are there, in some institutions maybe or the university you have 10 to 12 programs are there, and how exactly combining all the courses which are recommended to the each program can be implemented successfully. That in the next sessions we will be highlighting on that. Thank you all. Just.
Thank you, sir, for orienting us to the paradigm shift in curriculum from knowledge to performance and outcome, from teacher-centered to student-centered learning, and the importance of faculty training in competency-based education. We will now move on to the next session.
Once again, good morning one and all gathered here. Now I welcome Dr. Sunita Saldana, a distinguished professional with over 23 years of experience in the field of hospital administration, operations and academics. Her expertise spans the management of super specialty healthcare institutions, quality assurance, academic leadership and research. She holds the position of chairperson for 3 boards of studies, chairman of the Faculty of Allied and Healthcare Professions, and is an active member of Academic Council of Yenepoya, deemed to be University. Ma'am serves as a member of Board of Management at Yenepoya, deemed to be University, external member Board of Study, Allied Health Science, PG of Rajiv Gandhi University of Health Science. She also played a key role in academic reforms, including introduction of National Credit Framework, across all allied and healthcare professions, enhancing curriculum structure and student outcomes. Ma'am had organized national, regional conferences and numerous continuing medical education programs, faculty development programs fostering academic collaboration and knowledge enhance. Currently, she serves as a Dean of Allied and Healthcare Professions, overseeing 4 key academic units at Yenepoya, deemed to be university. She is an executive member in Consortium of Aggregate Healthcare Organization, Student Engagement Committee, and chair of the CAHO SEC Allied Wing. At present, she is also the President of PG Board, Karnataka State Allied and Healthcare Council. Now I welcome you, ma'am, to take over the session.
Thank you. Good morning to all. I am very sure all are overwhelmed after seeing our curriculum of NCAHP. Everybody is confused what to do, how to go about. And as Sir was mentioning of span of attention, it said 20-25 minutes, like people like us. We have some Gen Zs as well. I cannot cut short to 6 to 8 minutes. I will be taking you to 20 to 25 minutes. My overview of the whole session is on the National Council, Allied Healthcare Council curriculum, the vision, mission and the objective. Starting from there, understanding of the CBE framework. If you go across these 13 curriculums, its CBE framework is there, may not be defined very specifically, but it is across. The graduate attributes, what is expected, and the program outcomes, course outcome, program specific outcomes, and the alignment. At the end, the program outcome, the course outcome, and your assessment. At the end, it has to be aligned when we are talking about competency-based education. As we already know, NCAHP Act 2021, the guiding principles, if you go through across, the purpose is, yes, regulation and standardization, registration, assessment and registration, research and development, standardized curriculum, that's why we have one nation, one curriculum, and professional identity for all of us allied and healthcare professionals. So this one nation, one curriculum, if you go through, what does it say? What are the competencies it is talking about? Across all these 13 curriculums, it is talking about clinical skills, it is talking about communication, it is talking about evidence-based practice, it is talking about ethical behavior, patient safety, professionalism, and teamwork, and that is what is required for an allied healthcare professional. So when we talk about CBE, it is talking about preparing our graduates ready to perform or work from the day one. So as already Sir had mentioned, the focus is shifted. Focus is shifted from the teacher-centric to the student-centric. It is not, we are not talking about as a teacher what I am teaching. We are talking about what the student or what skills student is going to acquire. So the complete focus is on the student and their graduate attributes. The knowledge, the skills, professional behavior, and we talk about outcome-based approach, and all this has to be measurable. We have to measure to say how much they have achieved or they have obtained. That is what competency-based education talks about. Now if you see OB and CBE, I think you must have come across this word. We say outcome-based education, somewhere we say competency-based education. What is this? What's the difference when we are talking about? So when we say OBE say what should the learner be able to know or do by the end of the course or program. Here again the concept is program and the course. When we say program, bachelor's of physiotherapy, B-Optum, these are all the programs, and the courses are the subjects which we used to call as the subject, we call those as courses. That is what we talk about, programs and courses. So when CBE we are talking about, we talk about can the learner actually demonstrate this ability in real or clinical situation to the required standard. That is what CBE talks about. So if I could go further, in OBE it defines learning outcomes at course or program level, usually tied to a fixed time frame. Like I say, by the end of this semester or end of this year, this is the outcome what my student or a graduate should acquire. That is OBE. So if I'm talking about CBE, we are talking about mastery. We are talking about competencies of knowledge, skills, attitude, with performance is in real or simulated context, often allowing flexible pacing until the mastery is reached, until your student, your graduate acquires those attributes. So what are those core graduate attributes which is specified across the NCAHP curriculum? It is talking about professional competencies, it is talking about clinical care, it is talking about the disciplinary knowledge specific to the discipline, it is talking about psychomotor skills, problem solving and critical thinking, interpersonal communication. It also talks about how he or she can be working as a multidisciplinary team, socio-cultural and multicultural competencies, because they're all healthcare workers. There's a different settings they have to work. Sometimes we find students when they join for the program and they say, no, I could not adjust for this, I'm from a different place. No, we are into healthcare and we have to prepare our students to whatever the cultural variations we have. Ethics and lifelong learning and leadership and mentorship. This is what the graduate attributes we are talking about. At the end, once they acquire all this, they become the part of our Indian healthcare system, which is that what is, the ultimate aim is that, right? A graduate has to become the overall part of an healthcare system. Domains of learning. If you have gone through Bloom's taxonomy, I'm sure all of you know, we divide into 3 learning domains. One is knowledge, that is the thinking. And then it is the skills, psychomotor, and then the attitude or affective domain we talk about. That is how being. Can anyone tell me which of the domain is important for an allied healthcare professional? Yes, if you say all important, but if you want to tell which one is very much important, I will go for attitude. Of course, skills is a mandatory requirement. It is the attitude, it is the professionalism, it is the communication, it is ethics. This is very, very important. So, all are, if you are talking about the classes, course outcome, when you are talking about, we are talking about knowledge. First level, in the first year, you will teach them, classes are conducted, they are acquiring knowledge about the subject. And all our programs are skill-oriented. So they'll have to learn the psychomotor skill. Imagine that you are assessing the student to take history taking, right? And how do you assess? How you will assess? You'll give a question and they write a note on history taking for specific this, right? Your student will reproduce. In actual situation, if you put your student in that actual situation, do you think your student will be able to do it? He may be. You're not sure. Right? He may miss some step. The psychomotor skills, actual skills, what they are acquired is what we are talking about, skills here, and the attitude. Even if I am taking history, how do I make my patient comfortable? How I ask or respect my patient? These become a part of the learning. So the learning of today is inclusive of all these three domains. So further on, cognitive domain, knowledge. Again, if I go through the Bloom's taxonomy, the verbs what we usually use is remember, the different levels from the basic knowledge and I go to the advanced knowledge throughout. Again, please go back, just go back your syllabus, what you have gone through, and if you're looking at the first year, second year, third year, the levels from basic to advanced, everywhere there is a knowledge component, and you will be talking about remember, recall, facts, definitions, right? This is all knowledge. Then there is understand, where you say explain ideas or concepts, that becomes understanding. Apply, you are using the knowledge in practical situation. Suddenly there is a patient coming to a trauma care unit, the TCM student is there, how he or she is applying the knowledge. Analyze, break information into parts and interpret. Evaluate or judge or justify decisions or create, combine elements to form new ideas or plans. These are the different levels when we are talking about cognitive domains. I'm just trying to give you an example here. I've taken anesthesia OT department. I'm not from anesthesia OT department, but I've taken an example from that field. And this is again from your NCAHP curriculum, right? So if you say, if you're asking your student, recall facts or remember, how do you want to do it? You want to assess, they'll say define types of anesthesia, right? Understanding, you will the concept like explain OT zoning. Apply, application of infection control protocols. Analyze patient monitoring data. Evaluate safety risk in OT. Develop an airway management checklist, right? This is how your knowledge components, these if you see across your syllabus, similarly to other curriculum, you will find this, right? The knowledge, the cognitive domain. Psychomotor, perception, you show them the instrument and they recognize, right? Psychomotor skills. Now, some of the models which I have taken based on these domains, the skills are doing, I have identified. Set, readiness to act, guided response, performs with supervision. Your student is performing with supervision. Mechanism, that is performs routine skills independently, the routine, preparing your patient. As an anesthesia OT technology student, they have to prepare the student. Independently, he is able to do. Complex overt response, performs complex skills smoothly, or adaptation or adapting the skills to unexpected situation. Let's check again with anesthesia OT and we'll see what. the skills we are looking at here. So, positioning a patient. It becomes perception, recognizing, it may be instrument, cues. Here, positioning the patient is the perception. Preparing the anesthesia workstation. Performing airway management here. How did he perform? Setting up OT instruments and drapes. Monitoring ECG, SpO2. Responding to an unexpected drop in BP. Right. So these are the psychomotor skills we are talking about. The skills doing. This is only one component. I'm telling just with some examples. So this goes throughout your curriculum. It is being identified. Then comes the most important affective domain. That is the attitude, behavior, professionalism. We talk about values, ethics, empathy, teamwork. I am very sure all the teachers, this must be a very challenging task, because most of the time our teachers, we complain, our student do not know to wish, they do not know to give respect, they do not know this, they do not know do that. But we require to teach them these things because they deal with patients, right? And this is an important domain. So we talk about here awareness and willingness to listen. Now after some time they say, this is what every patient is coming with the same like this hue and cry. I am tired from the morning till evening listening to all the cries, in the anesthesia OT. So how do we show empathy to our students? Working respectively in a team, because the whole healthcare system works on team, right? And how your student is prepared to work in a team. Showing commitment to values, following ethical guidelines, maintaining confidentiality. This is a very, 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 very important. We always want, being a human being, we always, we want, you've got this information, we want to share, right? So it's not like that. It's the patient privacy, patient confidentiality. How is that they maintain? And demonstrating discipline and punctuality. I'm sure all of you must be having hard task to inculcate discipline your student, bringing them to the class on time, right? These are important attributes which we have to teach. So now, if I am putting this, the competency, for each competency, the cognitive, the psychomotor, and the affective domain, this is how it is. So, assistant airway management, as a cognitive domain, you will explain airway anatomy, right? Then, as a psychomotor, perform mask ventilation, prepare devices. Effective, maintain calm, collaborate with team. Even your assessment has to be based on this. So it all starts from the program outcome, specific learning course outcome, program specific outcomes, then course outcome, specific learning objective. I think sir mentioned on the lesson plans. When we are talking about the lesson plan, we are talking about specific learning objective. Your course outcomes are divided. You are supposed to divide that into specific learning objective, and that has to be in your individual lesson plan. If it is a 1 hour class I am going to take, what is the learning outcome today's class I expect from my student? So it has to be broken down into that. And your assessment should be connected to the same, right? We have seen many a times how the question papers are framed. The question paper framed person is confused, the student is confused, evaluators are confused, right? Because we don't have structure. So assessment, so touched on something, you will be having some more next to next. So cognitive domains, we talk about written examiners, Viva, MCQs, case discussion. You see your curriculum in NCAHP, they have given portfolios, OSCE, OSPE. So which assessment you are taking for which kind of domain? What kind of assessment? So you cannot assess psychomotor with in an essay question. Can you do that? Not possible. We were doing it, but that's not the right assessment. Right? It has to be on, if you say psychomotor, go to OSCE, OSPE. Or direct observation. Right? These are the different methods. Then affective domains, professionalism, 360 feedback, logbook reflection. I think even in our curriculums it is written, portfolio, logbooks, these are mentioned, required to have logbooks. Every time you send your student to the practical, have a structured system so that what they do there, what did they learn? And is that learning is part of the course objective? Every time a student goes to the clinics, the course objective should be defined. You are going to the clinic to learn this. If you are observing the procedure, this is the course outcome or this is the course objective which is you have to meet, and that has to be defined. Why these domains matter? Because for the holistic competency, it is the knowledge, skill and aptitude. It improves patient safety, standardized teaching and learning across the institutes, and of course employability and professional excellence, not only within and as well as abroad. So how these domains are integrated in a CBE system? So we spoke about graduate attributes. We spoke about program outcomes. Many of the NCAHP syllabus, it is defined. Somewhere it is given some objectives, somewhere it is program outcomes. I actually want you all to, my recommendation is you go back, sit with your team and put this into this system. I'll tell you it will be a very, very good exercise and it will help you to connect with the program outcome, to the course outcome, to the course specific outcomes what they have to learn and your assessment. So there will be a continuum in whatever you are teaching, learning and training and assessment. So everything has to cover all the three domains of learning. Whether the attributes, the program outcome, program specific outcomes. So if you see the NCAHP syllabus again, there is general program outcome like patient safety, right? It is a general. Then program specific outcome for program of anesthesia OT. At the end of the program of bachelor's in anesthesia or baccalaureate, what we call in this NCAHP, what is that is expected? Program specific outcome. Then we have courses, each what we call the subjects, like introduction to anesthesia. There you have course objective. This course is divided by units, right? Course specific outcomes, the specific to that unit. You again divide that into your classroom teaching, which is individual 1 hour or 2 hour class, right? So that is how it is divided. And your assessment again based on what is that they require. If you, most of the time, including me, when we value the paper and come, I taught them so well, but then at the end they did not write anything. Many a time I call my teachers, why the student perform? No ma'am, we taught everything. So many times, again and again, but they have not. Why? We have not told them, this is course objective, or this is what we are meeting, this is how it has to be done, and I'm assessing also in the similar way. So I prepare my students also. They're part in your whole this training system. I cannot finish all this in detail in 30. This is a long way to go. We will be having lot more workshops. Maybe eventually we will be going into it. So let's look at the POs, PSOs and course outcomes. So if you say, apply clinical knowledge and skill safety, demonstrate, these are all the program outcomes. If it is apply evidence-based practice, uphold ethics and professionalism, communicate effectively, engage in lifelong learning. Now what happens to program-specific outcome? Those are the program outcomes. So this is the program outcomes, right? What is the program-specific outcomes? PSO1. Prepare the OT, ensure sterility, manage equipment. Now this is specific to the anesthesia OT. This is specific outcome. Assist. Assist anesthesiologist in preoperative, intraoperative and postoperative procedures. Maintain infection control and biomedical waste protocols. Recognize and respond to anesthesia related emergency. The verbs what you use also very, very important, right? Now what happens to course outcomes? So course outcome in the same, there is one course called in anesthesia OT, Basics of Anesthesia Technology course. So you have course outcome for that particular course, identify anesthesia equipment and components. Assist in preoperative assessment. Prepare the operation theatre adhering to sterility. Conduct postoperative monitoring and documentation. Hope I have tried to make and relate how it flows. The program outcome, program specific outcome and the course outcome. So why it requires to be mapping? Why we require to map it? Can anyone? At the end we want the attributes to be acquired by a student, right? So if we are prepared like this, the outcome is better. So this creates its alignment of a curriculum, logical progression. So what you are also building the level. First year you are concentrating on a cognitive domain more, right? As you build up to the second and third, you will go into a psychomotor and attitude levels. When the fourth is usually internship, most of the program, it's completely psychomotor and attitude, right? So it is built, the acquisition of knowledge and the skills and all the domains, it is built progressively. And very important, measurement of their knowledge, that is the assessment and evaluation. And also we are meeting the requirement of the NCAHP. This is little too technical for this session, but since in my session I have a mapping, I'll just give you again with an example. How do we map? You have a program outcome, you have a course outcome. It has to be mapped, it has to be connected. You have, say, in the first year or the first semester, 4 or 5 subjects or courses you call. Second semester you have third, fourth, fifth, sixth. Now this has to be mapped with your program outcome, right? So you have to map how much. It is like we divide into high, medium and low. Now if I am, again you can see this anesthesia OT again. There are program outcomes, then there are course outcome. How it is mapped? Clinical skills. So your course outcome of that course is identify anesthesia equipment. What is the level they should understand? What is the mapping here? It is high, because they have to know this. This is the core competency what they require. for particular in this subject. In this way, you will be mapping every course to the program. So, each program outcome, it is mapped throughout all the course outcome. And that's why we are telling, once it is mapped, assessment is also based on that, and you will say, yes, my student has acquired these attributes. Right? I was talking about specific learning objectives. So again, your course outcomes are broken down into micro level. Sir has touched that thing. Now, example I am going to give you on the anesthesia OT, where differentiate inhalation agents versus IV induction. Now it is specific. Again, we are going in deep depth, in detail. So you see the connectivity from the program outcome, program specific outcome, course outcome, and specific learning objective. Right? So we always say when the lesson plan is done, at the end of it, even the assessment question should be there. How you are assessing? Because you have to, the question to be framed based on the course objective. Right? It should be very clear. It should not be confusing. We also expect student to write something, so we said explain, we say enumerate, just generalize. No, it has to be specific. If we prepare a student in the similarly, the assessment also, they will be doing better. So, again, as I already explained, so year 1, it is foundation skills, year 2, hands-on preparation, independent monitoring. See, it is built, the level is built from the first year to second year to third year. So, the progression is based on competency. So, CBE is not just an educational trend, it is a necessity in healthcare. When done correctly, the PO-PSO matrix, clear expectations, transparent assessments, high quality training, patient safety, better career readiness. In summary, the flow is vision, mission, program outcome, program specific outcome, courses, course outcomes, learning objective, assessment tools, competent graduate. This is how it is mapped from the program till the end. So the structured alignment ensures every allied healthcare graduate is safe, skilled, and workplace ready. So, in conclusion, again, I want to emphasize it is not just the trend, it is necessity for all these reasons. Thank you.
Thank you, ma'am, for sharing us the informative session on framework of competency-based education.
Good morning to all present here. I am delighted to introduce the speaker for this session, Dr. Senthil Kumaran. He is an additional professor in the Department of Physiotherapy at the Manipal College of Health Professions, Mahe, Manipal. With over 25 years of teaching and research experience, he has significantly contributed to the fields of stroke rehabilitation, virtual reality and game-based rehabilitation, posturography and interprofessional education. He has received 11 research grants from national and international agencies, published more than 70 scholarly works, and supervised 8 PhD scholars and 58 postgraduate dissertations. He has under his credit 4 registered patents, 6 copyrights. His contribution have earned several prestigious recognitions, including the World Physiotherapy Bursary Award and the Best Oral Presentation Award at the National Rehabilitation Conference. Dr. Senthil Kumaran is also a reviewer of leading journals. His work continues to advance innovative rehabilitation practices and strengthen physiotherapy education in India and abroad. Thank you for your presence, sir, and I kindly request you to take over the session.
Thank you, ma'am. Good morning, everyone. I think my job became a little easy because sir provided an overview, ma'am further explained, so you might feel some repetitions. But I think what I'm going to talk is getting into the water, because when we say competency, it is how we are going to assess our competencies. So that comes under the assessment. That is what this session. So I acknowledge the contribution of NCAHP because most of the things were taken from that one. And also I disclose some of the images that I'm going to use in this PPT were AI generated. So this is a brief objective for this session, but I won't take much time. I'll try to complete within the time. But you will be able to understand the differences between the traditional and then competency-based education curricula. There are different methods of assessment, is it direct and indirect, so you'll come to know about that. Formative and summative. Then how to apply these assessment strategies. I think ma'am already briefed about that across 3 domains. And how to integrate, what we are supposed to do in terms of assessment. So I'd like to start with this slide, and then I'll put the same slide at the end so that to know the differences between the traditional and then competency. So if you see the traditional curriculum, the assessment, I'll be talking more about the assessment and then evaluation only. So in the traditional curriculum, the primary focus of assessment is what the student or how much the student has learnt. So most of the time the primary focus of assessment is to know how much the students has learnt. Assessment type most of the time summative, predominantly summative. How often we do? It's a time based. Like for example, the first year is there, we assess. If the student has completed, then they go to the next level. We don't look at the mastery. We just look at, okay, the student has learnt, they go to the next level. And most of the time, assessment is indirect. I'll talk about that, what is direct and indirect in the later slides. And predominantly, we use 2 tools, like for theory exams, written exam, and then for psychomotor skill practicals. And most often, almost 80 to 90%, we assess only cognitive domain. This is the most important aspect. We hardly produce or provide any feedback. That is where the competency actually changes completely. And learner role, I think enough has been mentioned already, it is a passive role. So this is the current scenario in the traditional curriculum, what we do when it comes to assessment and evaluation. Now, I'm not going to talk about this because they both explained, but I wanted to say certain things just for the reinforcement. Competency-based education is an outcome-oriented, learner-centered approach in which everything revolves around the competencies. Your curriculum, your teaching and learning, your assessment, everything is focused on one single word, that is the competencies that are required for the professional practice that we are going to lie down based on this document that is provided by our National Commission. So in this, the learner progression is based on the ability to perform those competencies. Suppose as a teacher, we prepare the competency, how the progression is measured is this particular student, whether he demonstrated that particular competency which is required for the professional practice, so that we can say that that particular student is ready for professional practice. Doesn't go with the time. Like I said, the time is progression is not based on the time. We always have to look at whether that particular student has learnt that particular competency or has become master over that competency. So that is the whole or the sole crux in competency-based education. And it emphasizes different things like direct observation. This is another one. You need to observe directly their competencies. This is where again the traditional curriculum differs. No, we do not see most of the time how our students perform. So it's directly you have to observe. That is one of the main emphasis by the competency-based education. Workplace-based assessment, authentic workplace-based assessment. When we say workplace, for us it's a clinic or the hospital. So workplace-based assessment, frequent and formative feedback. See, this is again the one thing that which we miss. We do not give the feedback. So basically what happens when we do not give feedback, the student will not know what is their mistakes. The student will not go to the next level by correcting their errors. So that is emphasized in competency-based education and programmatic decision making. And finally, it emphasizes or it makes or it helps the graduate to achieve the expected level of proficiency which is required for their independent professional practice. So this is what the assessment in competency-based education is about. And key features, again this is a repetition, it's focused on competence. One, it focuses on the competence rather than the time or credit hours that the student spent in that. And it observable and measurable competencies. I think ma'am said about this also. You have to observe. We have to do direct assessment. There are indirect, we'll come to that later. And programmatic assessment with multiple small assessment. No, it should not be like one time you assess. You have to have, or we have to have a multiple low stakes assessment. And again I said direct observation and feedback rich learning. We need to give feedback to the patient whatever they do, irrespective of the domain. An emphasis on learner-centered, flexible and adaptive progression. And finally, the integrate to the entrustable professional activities. EPA is another one main component of competency-based education. When you say EPA, it is nothing but the task that is entrusted to the learners once competence is demonstrated. For example, when they come to clinic, one of the EPA can be like the patient, student should be able to perform the assessment independently, or the student should be able to perform the comprehensive assessment under supervision. So when I say these are all the EPAs, like entrustable professional activities. Now, though I am mainly talking about the assessment, I would like to just give a idea about the evaluation. We all know what is assessment and what is evaluation. The assessment is ongoing. It is about how the students are learning. Whereas the evaluation is the end that we give about the program feedback. So when we say assessment, again, already I said, it is systematic, continuous, where we look, where we observe, assess, gather the evidence of their competency progression. And mainly here it involves providing the feedback so that the improvement that we can see, and finally the students are ready with the EPA, like entrustment readiness, so that they can directly go to the field and then start practicing independently. Whereas evaluation is the overall judgment. That doesn't focus on each and every component. And these, we have some standards met. Like for example, if anyone joins for physiotherapy, 4.5 years or 5 years they have to do, they have to get these grades. That is the standards met. And then once if they achieve that particular outcome, we make some decision, and then we issue certificate for the degree. That is what the evaluation is. It's a comprehensive. Finally, so you know the effect of your program, or it's an overall assessment. That is what evaluation. I'm not going to talk about the evaluation. My focus is only on the assessment. We all know about this pyramid. What's this pyramid? You know the name of this pyramid? Miller's pyramid. We all know 4 levels, like knows how, shows how, and then does. Competency-based education has one more level. It's actually not the separate, but that is the peak of these assessment, that is called entrusted level or entrusted. Means the patient can do, I'm sorry to say patient, the student can do, but how much that you can entrust on their performance. Now whether they are eligible to practice independently or with the supervision, or they require some more amount of training, that is what the top level in CBE. So it's a 5-level CBE pyramid, that is a EPE. Now this is, I'm skipping, we already said the assessment is where we focus on verified performance capability, you do multi-dimensional assessment, and according to our NCAHP curriculum, assessment must reflect demonstrated competence, not just theoretical understanding. So for this, there are different methods are there. The first one is the direct and indirect assessment methods. What is direct? Direct is where you observe, so that you measure or you just evaluate the learners demonstrating competence in real or simulated environment. Like ma'am said, initial 1 or 2 years, it can be in the simulated, but the third and fourth, definitely it has to be in the real world. There has to be a patient, the student has to evaluate, and then we need to see all their component of that ability, or all the components, ranging from assessment, decision making, everything. So that is what the direct assessment method, which is a performance based. We don't need to worry, already NCAHP has listed down some type of direct assessment methods. The one is OSCE. I think this is, we all know what is OSCE and then what is OSPE. Both are same or different? Both are similar but not the same. So when we say objective structured clinical examination, it is with the real or simulated patients the student has to do, where the assessor also can provide feedback, interact, you can take more time, you can even assess a decision making and everything. Whereas objective structured practical examination is like a spots. We have a spotters, you have a station. Even in clinical examination also there will be a station. But where the interaction between the assessor and then the student, teacher and the student, can be more in clinical examination, because where you assess mainly their clinical skills. Whereas the practical is you ask the student to perform and then you just note down, you have a checklist and then you give what. So the interaction will become it's very limited. There is, this term is, looks new, but what we are doing already is that case presentation we do, right? That is what this objective structured long examination record. It's called OSLR. Like we give a case and then we give some 45 minutes or 1 hour to the student, and then they do complete assessment and then we go to them and then we assess. That is what this OSLR is. Then mini clinical evaluation exercise. This is a workplace-based assessment. When we say workplace-based assessment, it has to be done in the clinic. So mini case clinical evaluation exercises, you take one component of that particular. No, it's not a long case. Maybe I go and then I ask the student to talk about the observation skill, or I can ask the student to show one particular skill, or I can ask the student actually to show the X-ray and then identify the parts. It can be anything but one particular component, but again you have to give a heavy feedback to the student about their performance. Then direct observation of procedural skills. Ma'am was talking about the history taking. It's very difficult, history taking, how they do. We generally give the long case, then we go later, then the student says this is what the history. The direct observation procedural skills gives us an opportunity to see how even they are doing. Like you can give only one component, history taking. So the student has to take the history, where we sit and then observe how they are taking the history. So it is again one of the procedure, direct observation of procedural skill. Not necessary it has to be history taking. You can give some one assessment also, like range of motion assessment or patient safety transfer. It can be anything. Case-based discussion is like, it is kind of unstructured. You go to, students will be there in clinics, they see the patients. You go there and then you take one particular case and then discuss with them. It is just a case-based discussion, what they are doing. It mainly focuses on the decision making. How do they come to that particular decision when it comes to treatment? So it focuses on mainly that is case-based discussion. Portfolio assessment, ma'am already said, it's kind of our logbook. The student, it is kind of an evidence which shows that what all the student has done in their clinical training. And multi-source feedback is another one, which is a direct, like 360-degree feedback. We provide feedback, take from the other students, take from the seniors, PGs or interns when you're assessing the UG students, or sometimes it has to include even the patient assessment also. So these all are the direct assessment method where we directly see what is their competency. Why it is important? Already I said, because you can see what they are doing. Okay, it's not how or knows how. It goes to the higher level and allows the observation of real life professional behavior or their skill level or how they communicate or how they do the procedures safely or how do they do even decision making. How do they decide? How they derive to that particular final decision. All those things we can observe directly. It's given in NCAHP document. I think already I said these are the things which I have taken from physiotherapy curriculum. It is said. So some of the things we can try. Moving on to the next indirect assessment method. This we all know we do most of the time. Mainly the theory exams, where we evaluate indirectly. We are not seeing them. We give some question, they write, and then we assess. So what happens unfortunately is even the case presentation somehow becomes like that. We don't be there, we don't see what they're doing, we give and then they come and then, because of a lot of factors and then we assess. So there is a possibility that even the methods I mentioned in the direct can become an indirect if you don't do properly. So indirect includes written examination, MCQs, short answers, long answers, assignment, quizzes, online test, self-assessment questionnaire. You can give to the student and then ask about their, how do they feel. But we don't need to rely, sometimes the students feel that they know everything. So, but it is not the only thing where we are relying on the student's capability, of course, but you can even tell the student also to reflect on their ability and then maybe we can give the feedback. Patient satisfaction surveys, it's also mentioned in the NCAHP list that we need to ask the patient also. There has to be some questionnaires and then ask the patient, are you happy with the way the student or the therapist treated? All those things. Did they communicate properly to you? So all those things comes under the indirect assessment methods. So these are the things which is there in the NCAHP document. Now, whether it is direct or indirect, we know now these are the direct method, these are the indirect method. How to implement, how to do when the students are there are two ways. One is formative and summative. I think this is, I don't need to explain in detail, we all know. Formative is over the period of time. Summative is one time point at the end. So it is during the instruction. Formative assessment is I take a class, like for example, I am talking to you, at the end of the session I take a feedback. That is what during the instruction, that is formative assessment. And of course, again I emphasize we have to give a feedback. Students will learn mainly from the formative assessment, not from the summative assessment. So our focus also should be predominantly more emphasis should be on the formative assessment, not the summative assessment. And summative is at the end of the instruction, how the student has learnt. Okay, some of the examples of formative assessment, since I have already mentioned about all the methods of direct and indirect, you can mix. Some of the things can be under the formative assessment, like skill, lab performance, direct observation of procedural skill, mini case evaluation, weekly clinical evaluation, mentor feedback, peer feedback or reflection logs. All these things can be actually as a part of your formative assessment. Again I say formative assessment is the only one which will help the learners to improve gradually and meet the competency benchmarks, not the summative. Summative is done. They have reached the end. So ideally they should not reach the end if they are not performing well in our formative assessment. That is how the system is supposed to be. The purpose, it guides the learning trajectory, promotes self-directed learning. I think ma'am mentioned, or sir mentioned about the number of hours. Self-directed learning is given most importance in the current education system, including NCAHP. We have to give time for the student also to learn. Our students are very smart. Don't think, their attention may be less, they may not read, but I can say definitely they are much brilliant than us. Only thing is, we don't know how to actually go to their level and then teach to them, because they are now technology children. We are not. So maybe we need to know how to actually engage with them so that they also like our lectures. And ensures timely correction of gaps. So that is the purpose of formative assessment. Summative examples are, you can do final, see OSPE and OSCE can be a formative, can be a summative also. Okay, or long case, practical competency exit test, logbook completion, end semester written exams, all these things are summative exam. Summative also is important because this is the one which finally confirms that the students are ready for the progression, ready to go to the internship, ready to go out even to practice independently. And most importantly, ethical standards will be set at that level only. Whether whether the students are doing safely or independently, all those things are assessed by the summative assessment. This is a mention in the NCAHP document. The third component of my talk is how to assess across learning outcome. I think ma'am mentioned it has to be in all three domains. Okay, cognitive, affective, and psychomotor. That we all know. Now, you know some direct assessment, indirect assessment, formative and summative. We just have to map it. Like for example, MCQs, Viva voice, case-based discussion, all these things can assess the cognitive domain also. But the focus is what the student know about that particular clinical condition, or maybe when it comes to basic classes, anatomy and physiology, understanding, or sometimes even the evidence-based practice foundations. See, these all can be assessed or has to be assessed under cognitive. The psychomotor focus will be examination assessment skills, electrotherapy. This is the example from physiotherapy, electrotherapy and exercise procedures, patient handling techniques, emergency care skills, or documentation of even physical findings. These all can be under the psychomotor. And then finally, the affective. Affective is very sometimes difficult to assess. You have to do a lot of assessment. For example, if you see ethics, whether they are, ma'am said the affective is very important. Of course, for a healthcare profession, the affective component is very important. Empathy towards the patient, accountability or communication. Nowadays, that's one problem with our children, like students. They treat the patient, they use the mobile. They don't have that empathy. They don't actually convey that empathy to the patient. They just do. So all these things has to be taught to the patient and it has to be assessed. Assessment drives the learning. Anything you don't assess, the students will not learn. So whatever you want them to learn, you make sure that there is an assessment component, there is a mark. Professional behavior, respect for patient rights and dignity. So all these things comes under the affective. And you can decide, like for example, patient feedback will help us to understand about their affective domain, whether they treated with empathy or whether they had that care towards a patient. Or professional rubrics, how they behave when they are in the clinical posting, how do they communicate with the peers, how do they communicate with us. So all those things, professionalism we can, or when they are in the interprofessional team, like PT with the OT, how they actually do a teamwork. All those things can be assessed under the affective. So now having said all these things, now going back to the first slide, what I said, the differences between the traditional and competency, or maybe where it's up to you to see where we are lacking and then what we should do. When it comes to the focus, we have to shift our focus to the competencies demonstrated. Not how much they learnt, what competency they do. See, nowadays if you ask, they'll go to ChatGPT, get everything and then give you. But competencies cannot be derived from ChatGPT or something. That is a skill that they have. If they know only, they can do. Assessment type has to be continuous, formative, summative. And progression is not based on the time. Once they get or become the master of that particular skill only, they can go to the next. And direct observable tools we discussed, domains, all three domains. Feedback should be frequent and structured feedback. It has to be documented also so that you know the progression. The first level how they did, the next level how they did. And finally, the learner role will become active and self-directed. There are something which we need to do. One is we have to combine direct and indirect assessment for every course, use multiple formative assessments before summative evaluation, create checklist. This is another one issue. When you have lot of assessment, when multiple faculties are there, or when the students are 100, 150, a single faculty cannot do, so two faculties. So reliability has to be maintained. So have proper checklist, rating scales, implement logbooks and portfolios, simulation-based evaluation, and ensure at least a minimum competency demonstration before they go to internship or before they go out from us. So that is the final thing. But we have lot of challenges also. Some of the challenges I just thought I put, maybe it's some of the few, but I thought of some of the solutions also. One is still we are not clear about the competency, how it has to be. So how to tackle that, we have to discuss. We have to decide. Like sir said, syllabus is we make. Curriculum is there. Syllabus we can make. So sit and prepare the competencies, what we want our students to learn. So have proper measurable indicators, and faculties can sit together and then we can come to a consensus building. It has to happen in every institute. Limited faculty preparedness. Many of us also don't know. So we should be ready for training, and we should conduct the training also on how exactly to be done OSCE or mini CX or DOPS, all those things. High workload, this is a major problem for any academician. You are supposed to go to clinic, you are supposed to teach, you are supposed to document, conduct exam. So what you can do, you can actually distribute the workload, like some of them are in the clinics and they take care of the clinical assessment, some of them are in the teaching, they take that assessment. So all those things, and better embed the assessment in the routine clinical training. When they are there, don't keep a separate time for assessment one day. When they are there, small component can be assessed when they are with the patients. Resource constraints, maybe we can start with a very low cost, like mini case evaluations. You can use simulation, role play. Okay, all those things we can start, and then later we can go in a big way. Inconsistent assessment methods, I said we have to use the rubric, we have to use the standardized checklist, and multiple assessor and repeated observation. That is also important. Resistance to change, this I don't think so. We cannot resist. Now it is from the commission. We have to change. No? So only thing is maybe conduct the orientation session for even student also, for us also, so that actually we can develop a culture based on the whole system. Documentation challenges. Can be a e-logbook. That is the best solution. Everything can be even E or LMS. Most of the institute now has LMS as per the NAAC criteria. So learning management system. Everything is online, you can do, which becomes very easy. Poor alignment across even the department. When I say department, I am talking about the academic and clinical side, teaching and then clinic. So we can have a meeting. What you want them to assess, if the same person is there in the same place, it's okay, like both the places. But some places, clinicians are different. Students go for some other place for clinical training, but we teach. We can meet, and then what we want them to assess, what we want them to observe, all those things can be planned, because every institute is variable. We have our own way of doing it. Student difficulty with self-directed learning. This is again important. So again, have a structured template, have a regular monitoring. And institutional barriers, now I don't think so, because of the policy, institute also has to follow the things. So to conclude, evaluation and assessment are designed to ensure that the graduates are clinically competent, not only competent, they do safe, and they become independent professional. So that is the whole idea of CBE. And for that, we should incorporate indirect and direct methods, formative and summative methods, and we assess all learning outcomes so that the learner truly achieve the required competencies. Sorry for that, physiotherapy. Competencies for any profession defined in the national framework. So let us move from content driven to skills driven. Let us focus on the skills. Let us move from the time-based assessment to the performance-based assessment. Let us not grade. Let us give feedback. Let us not just only grade. Let us give them, let us give feedback and then later do again the grading. Let us not just do only lessons, let us give the experiences to the student. And let us not decide by ourselves, this is what I'm going to do. Maybe you can ask the student also how you wanted it to be. So co-designed. And maybe we have to shift our role from being very theoretical to practical, because that is what competency-based education is. We have to make them a better, competent, independent professional in the field. So with that, I would like to thank the Karnataka State Council and then Yenepoya for giving me this opportunity. Thank you so much.
Thank you, sir, for the session on evaluation and assessment in curriculum-based education. Now we all proceed for a quick break of 5 to 10 minutes. Following tea break, we have the inaugural program.
May I have your attention? I request everyone to please settle down in the reserved seats. The guests will be arriving shortly.
Hello, 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 hello.
The guests are arriving. Kindly settle down.
I request all the participants to kindly settle down. The dignitaries have arrived. Just tell me when they come. Yeah. very good morning to all. May I request our esteemed dignitaries to kindly take their seats on the dais. Honorable Chancellor of Yenepoya Deemed to be University, Dr. Yenepoya Abdullah Kunni, our Chief Guest, Professor Dr. Iftikhar Ali, Chairman, Karnataka State Allied and Healthcare Council, Professor Rajesh Shanai, Member, National Commission for Allied and Healthcare Professions, Dr. Srinivas Murthy, Secretary, Karnataka State Allied and Healthcare Council, Dr. K.S. Gangadhara Somyaji, Registrar, Yenepoya Deemed to be University, Dr. G. Arunmaya, Dean, Manipal College of Allied and Health Professions and President, Undergraduate Board, State Allied and Healthcare Council, and Dr. Sunita Saldana, Dean, Yenepoya Faculty of Allied and Healthcare Professions and President, Postgraduate Board, State Allied and Healthcare Council. Good morning, respected dignitaries on the dais and the esteemed gathering. I am Avril Rebello, Associate Professor, Department of Hospital Administration. On behalf of Yenepoya Deemed to be University and Karnataka State Allied and Healthcare Council, it's my privilege to warmly welcome you all to the inaugural ceremony of the workshop on competency-based education in allied and healthcare professions and implementation strategies. Today, we are privileged to bring together distinguished thinkers, educators, policymakers, and leaders who are shaping the future of allied and healthcare education. Education is the most powerful tool to transform society, and excellence in education is the foundation of progress. Guided by this very spirit, today's workshop seeks to deepen our collective commitment to competency-based education by translating its principles into meaningful classroom and clinical practices. It brings together key stakeholders to examine measurable outcomes, ensure curriculum alignment, and explore strategies that strengthen the quality and relevance of allied and healthcare training. To begin this auspicious occasion with the blessings of the Almighty, we will have an invocation through the recitation of our sacred verses. I request our students to kindly lead us in the invocation.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم اقرأ باسم ربك الذي خلق خلق الإنسان من علق اقرأ وربك الأكرم الذي علم بالقلم علم الإنسان ما لم يعلم. In the name of Allah, the most gracious, the most merciful. Read, O Prophet, in the name of your Lord who created humans from a clinging cloth. Read, and your Lord is the most gracious, who taught by the pen, taught humanity what they knew not. Om Gurubhyo Namaha Shriyan Dravyamayad Yagnad Jnanayagnav Parantapa Sarvam Karma Kilam Partha Jnane Parisamapyate Tadvidhi Pranipatena Pariprashneena Sevaya Upadekshanti Te Jnanam Jnaninastattvadarshinaha Shraddhavam Labhate Jnanam Tatparaha Samyati Indriyaha Jnanam Labdva Param Shantim Achirenadhigacchati. These verses explain the supreme importance of knowledge, how it purifies the mind, destroys ignorance and leads a seeker to liberation. Jnana Yajna is superior to any material sacrifice. Knowledge burns all actions just as fire burns wood.
In this world, nothing is as pure as knowledge.
A reading from the book of Proverbs, chapter 4, verses 1-13. Listen to the father's instruction and pay attention so that you may gain insight. For I have given you good principles. Do not discard my teaching. Acquire wisdom and insight, and do not forget or reject the words of my mouth. Do not abandon wisdom, for she will protect you. Love her, and she will be your salvation. The beginning of wisdom is to work to acquire it, at the cost of all you possess. Strive to gain insight. Hold her close, for she will exalt you and bring you honor. If you embrace her, she will crown you with grace and put a diadem of splendor on your head. Take my words to heart, then the years of your lives will be multiplied. Because I have taught you the way of wisdom, and I have guided you along the honest way. You will walk with ease and run without falling. Always remember what you have learned. Your education is your life. Guard it well. The word of God. Thanks be to God.
Thank you for the meaningful and uplifting invocation. To formally welcome this August gathering, I now invite Dr. Sunita Saldana, Dean, Yenepoya Faculty of Allied and Healthcare Professions and President, Postgraduate Board, State Allied and Healthcare Council to deliver the welcome address.
The Honorable Chancellor Sir, the Chairman of Karnataka State Allied Care Council, Professor Iftikhar Sir, Professor Rajesh Shenoy, the National as well as State Council Member, Dr. Srinivas Murthy, our Registrar, Dr. Gangadhar Somaji, Dr. Arun Maya, President UG Autonomous Board, the Council members, other dignitaries, and the esteemed delegates, a very good afternoon to you all. The National Commission for Allied and Healthcare Professions initially released 10 competency-based curricula, followed by the addition of 3 more, making a total of 13. These curricula, being entirely competency-driven, are to be implemented from the academic year 2026-2027. As we enter this transformative phase, it is but natural that the more than 200 plus colleges offering allied health and physiotherapy programs may feel a sense of uncertainty about the way forward. In our council meeting under the leadership of Sir Iftikhar Sir, the foremost thought was the need to guide and orient all institutions regarding this major transition. Accordingly, the first orientation session was held in the month of September at Ramaiah University of Applied Sciences, which witnessed the participation of over 500 delegates. It was later decided to conduct zonal level workshops. Accordingly, this workshop, specifically catering to the institutions of Mangalore, Udupi, Karwar, Hassan, Chikmagalur, Kodagu, and Shivamogga. First and foremost, I take this opportunity to thank the Chairman and the Council for choosing Yenepoya Deemed to be University to host this important workshop. Thank you, sir. On this momentous occasion, we are deeply honored by the gracious presence of our Honorable Chancellor Sir, Dr. Yenepoya Abdullah Kuni, a great visionary and a firm believer in education and community well-being. Yenepoya Deemed to be University has grown into a center of academic excellence, known for its innovation, inclusivity, and commitment to service because of his exemplary leadership. His foresight has paved the way for the establishment of world-class healthcare and educational facilities that continue to benefit thousands across the region. Sir, your unwavering dedication to societal upliftment and your support for progressive initiatives inspire us all. We extend a warm and respectful welcome to you. chief guest, Professor Dr. Iftikhar Ali, the first chairperson of the Allied Healthcare Profession Council, Karnataka, exemplifies dedication and commitment to both education and community welfare. His passion for strengthening the allied and physiotherapy professions has been truly remarkable, and it is evident and testament to his invaluable contribution to the field. Sir, as we thank you for the opportunity to host this workshop, we welcome you for this program. Professor Rajesh Shene, Director of Padma Shri Group of Institutions, Bangalore, and a member of National Commission as well as State Commission, is also a President of Karnataka Allied and Healthcare Professionals Association, KAPA, has played a pivotal role in uniting allied health institutions across the state under a single progressive platform. We deeply appreciate the initiatives taken under his leadership in strengthening the allied health fraternity. Sir, we extend a warm welcome to you. A warm welcome is also extended to Dr. Srinivas Murthy, Deputy Director of Medical Education and Secretary, Karnataka State and Allied Health Council, a respected academician and administrator who has contributed immensely to the enhancement of medical and allied health education across the state. Sir, we welcome you. We are also privileged to have with us Dr. Gangadhar Somaji, Registrar of Yenepoya Team to be University, an exemplary academic leader whose vision, administrative acumen, and commitment to institutional advancement is a testament in all our endeavors. Thank you for all your support in hosting this workshop, sir. We welcome you. I also take this opportunity to welcome Dr. Arun Maya, Dean of Manipal College of Health Professions, the President, Undergraduate Autonomous Board, and we closely work together and we always discuss how best we can do for this council. Thank you so much for being here, and I welcome you. The other esteemed council members, principals, senior faculty members, all the enthusiastic delegates, on behalf of the State Allied Healthcare Council, I appreciate your passion and commitment for the field of allied and healthcare, which is evident through your presence in this workshop. I warmly welcome each one of you and wish you meaningful, enriching, and fruitful deliberations throughout the workshop. And I extend my heartfelt thanks and welcome to the entire team of organizing this workshop for their valuable support. Welcome you one and all. Thank you.
Thank you, ma'am, for your gracious welcome. Light dispels darkness just as education dispels ignorance. Today, the ceremonial lamp symbolizes enlightenment, knowledge, and new beginnings. I request our esteemed dignitaries to kindly come forward for the lamp lighting ceremony. May the radiance of this lamp illuminate our journey throughout this workshop. I invite Professor Rajesh Shenoy, Member, National Commission for Allied and Healthcare Professions, who is also the Director of Padma Shri Group of Institutions and President of Karnataka Allied and Healthcare Professionals Association, to provide an overview of the workshop and its objectives.
Good afternoon. Dignitaries on the dais, Chancellor of Yenepoya University, Yenepoya Abdullah Kumi sir, Chairperson of Karnataka State Allied Health Science Council, my friend Dr. U.T. Iptikar, Secretary for State Council, Dr. Srinivas Murthy, my colleagues in the State Council, Dr. Sunita, Dr. Maya, I can see Dr. Bharat here, Dr. Aditya, faculty members and faculty from Yenepoya. First of all, my apologies for having this workshop on a Sunday, calling you here. It was due to some circumstances we had to change the date and we had to call you. My apologies for that. I know how Sunday is, everybody waits for a Sunday. So sorry to have to ask you to come for this session on the Sunday. Second is, I thank on behalf of National Commission as well as the State Council to Dr. Yenepoya Abdullah Kumiji for having given us this place and making all the necessary arrangements. When we asked Dr. Sunita Saldana and her team, we were ready to do it and they are coordinated everywhere. And Dr. Yogaraj Gowda also was very actively involved in this. And I thank them for giving all these facilities and making it possible. A big round of applause for Yenepoya University. Overview of the session. I think session has already begun. 2 sessions are over, as far as I know. So I don't have much to talk. They will be doing much of the talking. Only I can tell you a bird's eye overview what the National Commission is doing. Because a lot of you may be having doubts and you may be requiring some clarifications because some of the information is coming, some of them are not yet there. So you may have a lot of doubts because syllabus has been released for almost 12 courses, specialities, and some more in the pipeline. And those which have come out also, some of you have some clarifications, doubts. Everything will be sorted out, but please remember that this council is not like a medical council or a dental council. Because we have 57 professions, it's not only one. 57 professions to handle, and to do all this, it's a humongous task. And people are at work, things will happen, but it may not move at the speed what you expect. But things will move in place, because earlier there was no orientation, disorganized sector it was. Now we are trying to organize it, so it will take some time, but step by step they are taking out. As you must be seeing the circulars issued by National Commission, almost every month a new circular is coming. Now I think just 2 days back we have received a circular that for admissions to allied health science courses, NEET is mandatory. NEET appearance is mandatory, not pass. So don't be confused. NEET appearance is mandatory. So this streamlines. What is happening is earlier, a lot of colleges used to take PU candidates and this PU or 10+2 courses were not recognized, not known. So a lot of things were going behind the scene which we never knew. So to streamline these things, each step is being taken gradually, and the ultimate aim what the National Commission plans is to have an exit exam also. That may not happen very soon, but it will take some time. They will have an exit exam for all the bachelor's candidates who want to move over to the master's as well. It's a kind of proficiency test which will ensure that quality of the people who are passing out, they are worth the degree what is being given to them, and they can work accordingly. The next thing is, many of you professionals may be worried about your registrations. Registration guidelines are going to be issued very soon, and registrations will be provided for everybody. And if somebody is left out, who have been in the field of allied health sciences, may not have adequate qualification to be eligible to register, you are also coming out with certain bridge courses. so that we will make those who are not eligible, make them eligible for registration. So these are also in the pipeline, which will be issued very soon. Moving on to the students and college registration, I think the beta version in the website had started and asked institution to register. Many of the institutions have registered already. Students also, you can brief the students, sensitize the students. This is important because without this registration, they will not be able to practice or work anywhere in India. And the registration will be one India, one registration. They will not have statewide different registrations. The guidelines will be issued by the National Commission. The implementation will be done by the State Commission. So this is the modality how the council is going to work in the coming days. The next guidelines what will be coming is for the conferences, CME credits, all those things are being worked out, but it will take some time. It will happen, lot of confusion about, I think I was talking to Dr. Sunita, psychology, clinical psychology, behavioral psychology, lot of confusions. It is natural that since earlier there was no registration or no guidance, the clinical psychology was left over and only MPhil, those who had MPhil, they were need to register with RCA. Now what has happened is since last year RCA also has taken over clinical psychology and they have come out with some nomenclatures. Whereas in allied also there are some behavioral psychology has been taken over. So there is a clear-cut demarcation. I think for this year they have allowed everybody to continue with as it is. But from next year onwards, behavioral psychology will be under the NCAHP, whereas the clinical psychology part will be with the RCA. And those who are completing their master's degree in 2026, they will be eligible to register for MPhil and go for registrations, those who have done clinical psychology. So please don't have any doubt or feel that you have been let down, because clinical psychology is being offered at various universities and colleges. So I think it is a responsibility of both the councils to see that these qualified professionals are allowed to register, that will be taken care of. Coming from next year, I think 26-27 is the year which NCAHP has told that all the guidelines will be implemented. So many of the colleges are getting ready for this, and this workshop is also to just make you aware what are the things in store for you and how to go about it. Though there are certain things which need to be ironed out, specifically when you go about the syllabus, they tell that 22,000 square feet required for each of the colleges. So if you have 8 or 10 colleges, it doesn't mean that you need to have 2 lakh square feet. Don't multiply it. So the common guidelines are also coming. I think hopefully by another month's time we will get a common guideline which addresses this issue, where there is no duplication of faculty, no duplication of labs, and no duplications of classrooms and infrastructure. These things will be addressed very soon. It will happen because the council is aware about it, commission is aware about it, and we will take it up. And rest, if you have any other queries, please address to the state council. They are always welcome. They will surely see that whatever queries you have at their level, if they want, they can address it. If it is not possible, they will try to get it from the National Commission and reply back to you. Because why I am telling this is, National Commission may not be in a position to reply each and every email what you send it to them. So it is always better route it through the state and you can get some reply or some answer for it. I hope I answered most of the queries what you have. I don't want to waste much of your time because you need to go ahead with the session. Again, I thank the Yenepoya University for giving me an opportunity to be here with you. Thank you.
Thank you, sir, for the informative introduction. It's my pleasure to invite Dr. K.S. Gangadhara Somyaji, Registrar, Yenepoya Deemed to be University, to address the gathering.
Respected Chancellor Sir, Chairman of the Allied Health Professions Council, Karnataka State, Professor Dr. Iftikhar Ali, Professor Rajesh Shane, Central Council Member, Secretary of the Allied Health Professions Council, Dr. Srinivas Murthy, Dr. Arun Maya, the Dean of Allied Health College of Manipal, Manipal, our own Dean, Dr. Sunita Saldana, faculty members, invited speakers, other dignitaries, and my dear delegates. Good afternoon to all of you. On behalf of the university, I welcome all of you to this unique workshop as well as to our university. I must thank the chairman of the Allied Health Council for giving us this opportunity to host this particular workshop here. Not just because this is the important thing, being spoken, competency-based education is one thing which everybody is speaking of now. Not only that, but also I am thankful to him for giving us this opportunity to showcase our facilities as well. In fact, in this university, we have been talking about this competency-based education since a long time, and in fact, we have a dedicated center for the teaching, learning activities related to all the faculty run by a faculty development cell under the university. The NMC has actually rolled out the competency-based curriculum to the medical graduates long ago, and in fact, the same thing has been getting extended to other professions as well. But why everybody is speaking about this competency-based education? If you ask my opinion, to be frank with you, during my MBBS, what I read through the curriculum, I am using probably only 10% of that. Remaining 90%, I just read because it was in the syllabus, because the questions were asked from those particular topics, and we were expected to know about those topics. Ultimately, only 10% of what I read as an MBBS graduate, I use it now, and probably I remember it now. Remaining 90% probably I heard through 1 year and left out through the other year, if not immediately, few years later. The same thing has actually happened to even engineering programs as well. If you ask our companies, are our graduates market ready or industry ready? The answer is no. Many of you may be aware, Infosys in fact conducts a separate program for training the recruitees on what they are expected to do. That means the basic education what they get in 4 years during their bachelor's degree is zero. That is not at all for industry. Similarly, during post-graduation, see, I have done a post-graduation in ear, nose and throat. Again, what we learned through patients and dissections and simulators is actually what helped me, and not the knowledge what I acquired through textbooks or classes or seminars. So ultimately what is required in every profession, whether it is health related or non-health related, is the skills. So how you are competent enough, how much you are competent enough to get those skills in you and implement the skills on the patients. So that is what is actually competency-based education. It is not enough if you are having knowledge. It is also equally important to have the enough skills and the attitude. To realize this, it took many years for our educators. What is really expected from the students, it took so many years, but at least nothing is late than never. So we have definitely made a good beginning. The formation of the Allied Health Council is good in a lot of ways. Regulation is always better. Regulation will bring quality everywhere. So better quality will always result in better outcome, in the sense the people are skilled and they are industry ready, and ultimately the patients are getting benefited, and it is the society ultimately which gets benefited as a whole. So I congratulate Dr. Sunita for having taken up this particular workshop in our university, and in fact I was going through the topics, and the entire competency-based curriculum is covered. In fact, what is important in any curriculum is to go retrograde direction, to understand what is required for the industry or the practice. From there, you have to start and grow and build competencies. And those competencies will have to be mapped with the existing curriculum. And we have to find out the gaps and try to fill the gaps. That is what actually is being done in this workshop. Probably after filling up those gaps, then what is equally important is to know the method of evaluation. Ultimately, if that is not good, our skill programs are not going to be complete. So it is equally important. The way to evaluate is as important as learning a competency. So that is what ultimately molds the person and makes him skill enabled, right? So I hope that this workshop is definitely useful for each and every one of you. And in fact, you can go and actually impart the skills onto the students. In fact, all of us here as teachers, we should stop delivering the content. Content is available everywhere now. See, unlike our days, it is available in print and media. Nowadays, it is not, our teacher's help is not at all required, I tell you. So what is required is basically, we have to be the coaches or the mentors or the guides for the students. See, for example, now when I am operating, I will show actually to the candidate what is this particular structure, how we have to do, how we have to operate, so how the outcome will be better if you adopt this technique. See, that is what required for the student. It is not actually the theoretical component of the surgery, like what is the indication, what is the contraindication, that they will know, right? So these kind of workshops will go a long way in making you educated about competency education, and you can impart the same onto the students, and ultimately everybody will benefit. Thank you once again for the council chairman for giving us this opportunity. Have a good day.
Thank you, sir, for your thoughtful message. It's my privilege to invite our chief guest, Professor Dr. Iftikhar Ali, Chairman, Karnataka State Allied and Healthcare Council, to address the gathering.
Good afternoon. My respected, my father figure, Honorable His Excellency Chancellor of Yenepoya University, Dr. Abdullah Kunisa, my counterpart, Secretary of the Council, Srinivas Murthy sir, my member to the National Council, Rajesh Anai sir, my counterpart, the main post who holds in the council, the two presidents, autonomous body presidents, the UG President Sunita ma'am, who is instrumental behind today's function by hosting it here, and the PG President Arun Maya sir, my teacher, my mentor for my school days, and Somaji sir, the dynamic registrar of this university, and that my council members, Kirti ma'am, Bharat sir, Yogaraj sir, Aditya sir, and all the members of the Faculty of Physiotherapy, Allied, and teaching faculty members of Allied of Yenepoya University, and all the members present over here. I think speakers, you already heard about the sessions, and I'm not going to talk much about this council because already you have, from morning you have sessions, again afternoon you have post sessions, and you, national chair member also spoke about it. I'm just here to talk to you 2-3 minutes. I can take your 5 minutes of your time. One, thank Yenepoya Abdullah Kunisa sir, who gave us opportunity by sponsoring the entire event from day morning to evening and helping Sunita ma'am to make it easier. Because when I selected Bangalore as a central team of Ramaya, then I thought of doing zone wise. Then when I thought of Yenepoya in the Bangalore zone. So next, Arun Maya should be ready for Bangalore zone is Manipal. Then will be Davangere, Rajiv Gandhi University. Then will be Gulbarga, Davangere University, Rajiv Gandhi University. And I'll come back to Hubli-based SDM. Kirti ma'am, you will be in charge actually for SDM, you will host that. So that Virendra Gade sir will preside over that, and our minister will preside in Kalburgi. And in Bangalore, Gundarao sir will preside over the meeting. So that by January end, This is my plan which I have not told you. And by January, I'm going to finish all the sessions. By February, I'm going to tell you now only, be prepared all the heads. You are the TOTs. Don't think you are just coming and sitting here. You're getting trained by the teachers today and you are going to implement that. So I'm not going to call it as today as a competency based. I'm going to call it a skill and TOT. I believe in practical things. By February, 100% I'll put a surprise inspection to all the schools, all the institutions. I was a bit liberal because I'm an easygoing guy. Because my team is very good. I have selected team on merits. Now I came to know who is Kirti ma'am, frankly speaking. Because I have taken all on records. I am seeing for the first time, now that's one more member is sitting down. Because even Sunita ma'am, it was surprise. Even surprise for Maya sir, surprise for national member, surprise for Bharat, my batchmate. Aditya sir membership was one single name clearance in the cabinet. His name was dropped out. Then I came to know he's very popular optometrist in Bangalore. We pitched him again. So this team was I am just a team head, but my team is extraordinary, doing well of teachers, the implementation. But I'm going to show we have the best council in the national in future. Because a chancellor for the more knowledge, sir, medical, dental, nursing, Ayurveda, pharmacy, naturopathy, all the councils have minimum of 250 intake, PG of 100 intake, all that, sir. But we have around more than 50 courses. Our colleges, implementing will be more than 1,000 students in one campus. Because we have already 13 curriculum has already come in, pitched in 13 curriculum. So if we count minimum 40 to 50 students also, we cross yearly intake of 1,000 students in a deemed university and almost 3,000 to 4,000 in one campuses. So we are the biggest council, and the advantage of the state council, the national council has given the power to the state council. Before, the national council is to do inspection for nursing, medical, dental, pharmacy, Ayush. But this allied council, state council does the inspection. We have given the power. So I'm going to make a trial round before the regular inspection. I will be sending our own team, senior people, how much you trainers who got trained today, what you have implemented in your schools, colleges. Like Mangala colleges, example, what Bharat has implemented to the students, to the faculty members, because you are going to train your counterparts. You are the heads now. Your vice principal is there. We will ask your staff, biochemistry, what your principal has told about this council. If it goes blank, means that you have not trained that staff. So please make use of all these things. Don't take it lightly, because you are going to be future members. We are going to give staff members as a first registration opportunity over here, because it's going to be a big rush in the camp. We have only 4 systems in biometric system in the council. So we are going to give staff faculty members, you will be the first 200 people to register coming to Bangalore. You have fast track facility, no waiting list. So that please make use of all these things. Train your juniors, try to give them support, try to, whatever little knowledge you have in your life, don't think that will give back to you. Don't do things to your juniors or counterparts, anyone, that they'll talk good about you, they'll give good return back to you. Never think about that. Just blindly do what is there for you, so that you'll be getting back with your children and your community. Don't do that to please her. That things won't happen in this society and this profession. I've seen in many things, because we have gone out of the ways to do things for people, that you won't get anything good about them by return. So I'm telling you, be very practical, because I'm a very practical person, and I didn't want this post. Rajesh sir knows in the last government, this was implemented in 2022, and I was a committee member with Rajesh sir, he was my chairman. I didn't want this post. I was called, given the order to, so that we will do something. Now, when you ask the national ma'am, Yagna ma'am, you ask her, the national president, what role model you need to be implemented in the state, country, she will tell open platform, madam will tell, follow Karnataka. Very simple. She will tell, follow Karnataka. So, we have popular universities like Yenepoya, Nitte, Manipal, SDM. We have 8 deemed universities, 17 private universities, more than 1,000 Rajiv Gandhi affiliated colleges, more than 200 allied colleges, more than 100 physiotherapy. So we have a strength of more than 20,000 students in a year passing out. Imagine once registration starts, we are going to have more than 2 lakh back people. Even I have to get registered tomorrow when the membership starts. So that will be a pan-India registration. You will be recognized all over the country. Then first you have implementation, we have a surprise inspection, and even implementation of 2026 pan-India curriculum will be have to implement. We don't want any reasons from anyone. Let it be private, deemed or government. I am going to stick on the rules that 5 years physiotherapy, doctor prefix, whatever it may be, that was a dream what we used to have before when we were students. When I studied in 1995, I think many were not born here 30 years back. And I was just, we had just 3.5 years BPT course and 3 years of physiotherapy and 6 months of internship, and not under Allied, it was under Man University, and we had a subject called massage example. So we are not recognized anywhere in Allied courses or physiotherapy. Now everyone recognizes us in equal partner healthcare, we were always to call as, and we are always be in the guidelines of management. We can show this time is, I am a regulating body, and Chancellor Sir is the institutional head, and Sunita ma'am is a teaching head, and you are going to have another, next is your students training. So the regulator is the ultimate body which will give directions to the institutions, and the institutions will be telling the teaching members, and teaching members will be sharing it with you, and you will share it to your junior teachers, and junior teachers will share it to students. So ultimately, if you want to hold your council online, and you are the main key players, and that's the reason we wanted to call the head of the departments together. And very soon in April, I have not decided the date, April, May, we are going to have discussed with Rajesh and I, sir, we are going to have a very big Allied National Council Physiotherapy on one background of national conference to be held in Mangalore. I'll take help of 4 private deemed universities, and I'll take help of other faculty members, which one historic one, we'll have more than 10,000 delegates attending that national head. And I'm so happy that staffs have come. Any from Shimoga, ANSAP, Shimoga? Nice. From Kodagu? Anyone from Kodagu? Good. Chikmagalur? Good. Karwar? Karwar we don't have Allied, I think. Udupi? Good. Mangalore? Nice. Thank you. And thank you, Chancellor Sir. I'm not going to talk much, because if I talk, I feel like talking to my students and faculty when it comes to my own profession. That has become my passion. When my brother was health minister, he used to tell me, why don't you start your own institution in your own brand? So I used to always tell you, I like to be always in the driver's seat. And now I told my Chancellor Sir, he called me sitting next to him in the boardroom. I told, sir, I'm always scared of a single chair. That's the reason I've given Srinivas Murthy my office. My office in Bangalore Council, Srinivas Murthy and Ogra sir sits. I never sat in my single chair there, because I always believe in even management head, so that you will, my things is when we die tomorrow, ultimately you should tell what you've done for your profession, what you've done for society, what you've done for your family. So ultimate goal is that, we have to always remember. So whenever we see that, I've told Arunmaya sir all this, when you do a next program, try to do always in your thinking only of your profession. Forget about other things, what you want to do. People talk, but don't bother. How much criticism you get in life, that much you rise in life. This is one example you should always learn. If you're not criticized, you won't get prosperity or rising, because you'll be a dummy person sitting at home like a mannequin. So I wish you all the best. Wish you do a lot of things in future for your allied profession. Thank you, management of Yenepoya Group. Thank you, my council members. Thank you, one and all.
Thank you, sir, for your inspiring and visionary words. We now move to a special moment, the Felicitation Ceremony, an expression of our respect and appreciation for the contributions of our esteemed dignitaries. I request our Honorable Chancellor, Dr. Yenepoya Abdullah Kuni, along with all university officials, to kindly come forward and felicitate the dignitaries.
I request our council members to come up. From the council we have to go, Bharat, Kirti ma'am. From our council we want to felicitate our chancellor who has given the space, place and all these things. We believe in elders first, and please, Bharat, come.
It's our privilege to felicitate Professor Dr. Iftikhar Ali, Chairman, Karnataka State and Allied Healthcare Council, whose visionary leadership has been instrumental in advancing allied and healthcare education in India and the state. We felicitate Professor Rajesh Shenoy, Member, National Commission for Allied and Healthcare Professions, for his tireless efforts in promoting excellence in allied healthcare education. We are privileged to felicitate Dr. Srinivas Murthy, Secretary, Karnataka State Allied and Healthcare Council, whose dedication ensures effective implementation of educational initiatives. We felicitate Dr. G. Arunmaya, Dean, Manipal College of Health Professions and President, Undergraduate Board, State Allied and Healthcare Council, for his contributions in shaping the future of allied healthcare education. We also recognize the presence of other council members, Dr. Aditya Goel. Dr. Aditya Goel, please accept our token of appreciation. Dr. Bharat. Dr. Yogi Raj Gowda. Dr. Sunita Saldana. Dr. Senthil Kumaran. And Ms. Anjali Kotin. Thank you, sir. It is my honor to invite the Honorable Chancellor of Yenepoya Deemed to be University, Dr. Yenepoya Abdullah Kunni, to deliver the presidential address.
Esteemed guests of today's function, Professor Dr. Iftikhar Ali Farid, Chairman, Karnataka State Allied and Healthcare Council, Dr. Arunmaya, Dean, Manipal College of Health profession and President UG Autonomous Board, KSAHC. Dr. Sunita Saldana, Dean, Yenepoya Allied and Healthcare Profession. Dr. Rajesh Anai, Dr. Srinivas Murthy, Dr. K.S. Gangadhar Swamiji, Registrar, Yenepoya, deemed to be University, Principals of Constituent Colleges, distinguished members of the Karnataka State Allied Healthcare Council, friends from the media, stakeholders, participants, faculty members, and esteemed guests, ladies and gentlemen. A very good afternoon to all of you. It's indeed a great honor for me to preside over this important workshop on competency-based education in allied healthcare professions and implementation strategies. This is a very proud moment for all of us at Yenepoya, deemed to be University, as we host this milestone event in collaboration with the Karnataka State Allied and Healthcare Council for principals, academicians and leaders in allied health education. The recently launched competency-based curricula for allied and healthcare professions by the National Commission for Allied and Healthcare Professions make a significant transformative milestone that will greatly reshape the healthcare education landscape. The value-driven initiative will streamline and standardize education across the nation, ensuring development of globally competent professionals equipped to meet the rapid evolving needs of the healthcare sector. It truly embodies the vision of one nation, one curriculum. I am delighted that the implementation of these curricula will begin as early as upcoming 2026-27 academic year. I must also take this moment to express my deep appreciation for the dynamic leadership of the chairperson of Karnataka State Allied and Healthcare Council and our chief guest for today, Professor UT Iftikhar Ali Farid. His passion, commitment and relentless drive are evident in every initiative he undertakes. I have known him personally as a powerhouse of action and accomplishment, a man whose deed speaks far louder than his words. I sincerely pray that Almighty continues to guide him and his team as they move ahead with their noble and transformative work. I strongly urge all principals and academicians of the allied and healthcare institution to take the lead in introducing, orienting and guiding the implementation of these strategies. Let us collectively give wings to this meritorious endeavor and make it a resounding success. I am thankful to the people here for felicitating me on this occasion. Thank you one and all. Jai Hind, Jai Karnataka.
Thank you, sir, for your inspiring and enlightening words. Ladies and gentlemen, we have Dr. Praveen Arun, who has joined us now. He is a council member and also a resource person for today's workshop. So we welcome you.
He is the president for the inspection committee.
So we welcome you, and I request you to kindly come forward and accept a token of appreciation. I request our chief guest to kindly hand over the token of appreciation to Dr. Praveen Arun. Thank you, sir. As we draw close to the end of the inaugural ceremony, I invite Dr. Srinivas Murthy, Secretary, Karnataka State Allied and Healthcare Council, and Deputy Director, Medical Education, Karnataka State, to deliver the vote of thanks.
A very good afternoon to all of you. Respected dignitaries and the faculty members assembled here today. I am here to deliver the vote of thanks. Before that, there is an important announcement regarding faculty development program. The Karnataka State Allied and Healthcare Council wants to establish Center for Allied and Healthcare Education in collaboration with Yenepoya deemed to be University and Maha University. This is with the approval of our chairman of Karnataka State Allied Healthcare Council, who has given the approval in principle to start these faculty development programs in these universities. The main purpose of this Center for Allied and Healthcare Education is to establish India's first Center for Allied and Healthcare Education, exclusively dedicated to capacity building and pedagogical framework in allied and healthcare education in alignment with the NCAHP's competency-based curriculum. The mission, vision and objectives of this Center for Allied and Healthcare Education is to make Karnataka as a national and global leader in competency-based allied and healthcare education by equipping faculty with advanced pedagogical techniques and leadership skills that directly enhance healthcare education quality, employability, and healthcare outcomes. The detail about this program will be given to you in consultation with our chairman after working out how to go about this program in future. And to give vote of thanks for today's function, respected Chancellor, Dr. Yenepoya Abdullah Kuning, Chief Guest of today's function, Professor UT Iftikhar Ali Farjid, Chairman of our Council, Guest of Honor, Dr. K.S. Gangadhar Swamyaji, Professor Rajesh Shanai, National and State Council Member, Dr. Sunita and Dr. Arunmaya, the members of our Karnataka State Allied Health Council, and distinguished faculty members, students, media personnel, and dear participants. A very good afternoon to you all. It is my privilege and honor to propose the vote of thanks on behalf of the Karnataka State Allied and Healthcare Council at this inaugural program and workshop on competency-based education in allied and healthcare profession and implementation strategies. First and foremost, I extend my deepest gratitude to our Chancellor, Dr. Yenepoya Abdullah Kuning sir, for presiding over today's program and delivering presidential address. Sir, your visionary leadership and commitment to academic excellence continue to inspire institutions across the country. My heartfelt thanks to our Chief Guest, Professor UT Iftikhar Ali sir, Chairman of our Council, for his insightful address and constant guidance in strengthening the allied and healthcare education in the state of Karnataka, and a remarkable individual whose leadership and dedication have left an enduring mark on allied and healthcare community. When the National Commission for Allied Health Bill was introduced in the year 2021, it took almost 4 to 5 years for the Karnataka state or any state to implement it. So because of this delay in implementation of the national bill, the Supreme Court has taken filed suo motu case on the states why this is not implemented. So for almost 2 years, our Department of Medical Education worked tirelessly in bringing out the rules, in nominating the members, nominating the chairman, and other things. For almost 2 to 3 years, things were not happening. And we received few letters from our chairman to make somebody else chairman to this state council. Then I used to attend meetings in the Director General of Health Service in the central government. Then every time they used to ask, when are you going to nominate, when are you going to frame the rules? Then I make him understand, sir, this is a difficult task. Only somebody like you who takes charge, instead of referring somebody or recommending somebody as a chairman, because I have the letters still with me where you are recommended. So we requested him to take charge as a chairman. The moment he took charge, the Karnataka State Council has gained a lot of speed and momentum in implementation of things. Within a week time, we got the rules done, which was not done for almost 2 years. And within 2-3 months, we got the members nominated. Within 2-3 months, we got the other members nominated because of his interest. Then we requested that, sir, it's not because of you, it's for the profession. You have to take interest and you have to do this job for the sake of the profession to establish in Karnataka. Then after our request, he has agreed. And now we are the number 1 council in implementation of the curriculum, whatever the directions issued by the central government or central commission in implementing. Thank you, sir, for accepting the chairmanship, this thing. And during the inaugural function of the Karnataka State Allied Health Council in the Bangalore Medical College, we had invited National Commission Chairman, Yajna Shukla Madam, and we were all sitting on the dais, but sir was not sitting on the dais. We requested him. He was reluctant, but he was standing down and he was organizing and he was overseeing the things that in this establishment or opening ceremony of the Karnataka State Allied Health can take place. So he is a true leader who is making others who are associated with him to grow along with him. So it's our selfishness also that we want him to grow more so that people who are with him also can grow. Thank you, sir. Thank you for your guidance and insightfulness. Next. A special note of appreciation to our Registrar of Yenepoya deemed University, Dr. K.S. Gangadhar Somyaji. Registrar, your continued support for academic innovations has laid a strong foundation for quality healthcare education, sir. We congratulate from the Karnataka State Allied Healthcare Council for your guidance. I also thank Professor Rajesh Shanai, member of NCAHP and member of our Karnataka State Council, for their enriching presence and contribution to the dialogue on implementation strategies, sir. My sincere appreciation to Dr. Sunita Ma'am, Dean of Yenepoya Allied and Healthcare Sciences, and her dedicated team for the meticulous planning and coordination that made this workshop possible. And I take this opportunity to place on record our gratitude to Yenepoya deemed to be University for providing exceptional facilities, seamless logistics, and a supportive environment that has greatly enhanced the quality of this workshop. Yenepoya University has always been a model institution for progressive healthcare education, and today's program once again reflects its commitment to excellence. And to all the faculty members, resource persons, invited guests, students, and participants, your enthusiastic involvement has enriched this inaugural program and set the tone for meaningful deliberation ahead. A word of thanks to our media personnel for their coverage and support in taking the message of this workshop to a wider audience. Finally, I thank every individual, named and unnamed, whose efforts have contributed to the success of today's event. On behalf of Karnataka State Allied and Healthcare Council, I once again express my heartfelt thanks to all of you. Let us continue to collaborate, innovate, and work together towards strengthening competency-based education and elevating the standards of allied and healthcare profession across the nation. Jai Hind, Jai Karnataka.
Thank you, sir, for your gracious and thoughtful remarks. As we conclude the inaugural ceremony, I request everyone to rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
I request district-wise who has come, Shimoga, Karwar, Udupi, to have a group photograph with the council members. Please come. District-wise you come. Shimoga, Karwar, Chikmagalur, Udupi. Then last Mangalore. Mangalore you can stand faculty-wise, optometry, physiotherapy. I want it for my council record, for my journal, okay? It's not for a photograph, for the council we need your... For documentation, very important. Seema madam. Come, please come.
Udupi separate, Manipal separate. Please. Udupi separate, Manipal separate. I need all the faces.
I know.
Bangalore, Sister, we get ready. Bangalore, next Sister, get ready, quick. Hassan.
One
Thank you. Hassan, come. Two people, come first. Allied science. Bangalore Allied. Organizing committee, Yenepoya. Yenepoya volunteers, organizing committee next.
Kind attention, please. I know it's a lunch time. This is just a 15 to 20 minutes Dr. Maya sir wants to speak about is because he wants to go later on because we are already late. That's regarding especially the first year, what's the plan, how it can be done, because you know we all have issues when it is coming, the first year syllabus, which is each specialty asking separate, so that brief overview and how to deal with it, what are the strategies, sir is going to speak for 15 to 20 minutes and then we will break for lunch. Thank you.
Rajesh sir.
Presentation time.
ಇದಾಗುದಿಲ್ಲ. ಅದಲ್ಲೇ Very good afternoon to all of you. Thank you for accommodating this session before the lunch. This is one important, I think, the topic, very essential to implement the first year curriculum of National Commission for Allied and Healthcare Profession Council. We have made the consolidated the course of each year or the semester and how exactly we can, some of the common subject, especially the pre and paraclinical, or some subjects like the courses like English or the constitutions, these all common courses are included in all the curriculum. Considering the required manpower of especially the pre and paraclinical, how we can consolidate and then plan the implementation of those courses in the first year of the UG. I will be highlighting only on the UG curriculum. I think the light, we can switch off the light here. Yes. Except two programs, the physiotherapy and the occupational therapy, it's in the annual pattern. Rest all the programs are in the semester pattern. And in most of the institution, the light we can switch off. These lights. In most of the institutions, you may be having the independent physiotherapy college, or in many of the allied health institutions, you have the programs with different programs comes under the one umbrella. All these programs are having the anatomy, physiology, biochemistry, or subsequently microbiology, pathology, and then the pharmacology and all. So it is important that the number of hours or the credits are varied from program to program. Earlier what we used to have, as we mentioned, the university level curriculum, there may be a similar number of hours of training is proposed in these programs, but now if you look at, this is varied from the programs to program. And when the institution is running these programs together, you have to think from the management point of view also. Every program you cannot have the separate anatomy teacher, separate physiology teacher, separate biochemistry teacher. Definitely it is looking at the cost of education. It is practically from the management point of view, it is not feasible. In such situation, how we can consolidate these, bring them together, and then we can deliver these specific courses. However, as I said, this is the thumb rule is always remember 1 credit of theory is equal to 15 hours, practical is equal to 30 hours, clinical is equal to 45 hours. This is the way the credit have been calculated for all the programs. And there are also, if you look at each course, there is a component of internal assessment, university examination. Some also we will recommend it as a non-university courses or the subject. Here the course means the subject. I will repeat that point again and again. It's a course means subject. There may be a non-university courses are also there. If you look at in few program, in a semester there may be 6 or 7 courses are there. So in that direction you have to think in the angle of student also. See, when you ask them to write 7 subjects in one particular semester, at the end you will get a significant failure rate as compared to the good performance. In those courses, in situation, some courses which are not directly related to their program or the specialty, but from the holistic development of the student's point of view, those courses are essential. That can also be taken as a non-university or the internal assessment. So this is the way we can plan and deliver. Then the next important thing is teaching method and evaluation. 2 credit and 3 credit paper. In some courses, if you see, anatomy is 100 hours or 120 hours. In some courses it is 45 hours. There is a unequal distributions of the credit hours is given to the thing. In those courses, actually according to the credit work framework policy, anything is 2 credit or lower, the evaluation needs to be done with a maximum of 50 marks. You cannot conduct the examination of 100 marks for a 2 credit paper. Anything above 3 credit, ideally the university examination needs to be with the 100 marks paper. And most importantly, as I mentioned earlier, the equal opportunity for the continuing assessment and the end semester examination is to be given. But here, in most of the programs like optometry, if you say it is a 70-30. In physiotherapy or occupational therapy, it is given 80-20. So in those cases, the continual assessment component have actually not projected properly. In that, how exactly we can normalize also. Then another important point is common subject can be combined in combining the program so that cost effectiveness, save the time, and also the less number of manpower is required to deliver these courses or the subject. But ensure that you should not exceed the classroom capacity of 150. Then otherwise it is practically, you will not, in those cases you can have the batch or the section A and B. I am giving an example when an institution is running the multiple program. There are many institutions are having the 6 or 8 program, 10 program, 12 program under the one umbrella. In those cases, if the maximum capacity of 150 should be an ideal thing, don't combine 300 students, 400 students and then deliver the anatomy. This is the way you can plan the implementation of the first year curriculum from 2026 onwards. I'll just give you an example here. This is the consolidated thing we did for the course wise. If you look at physiotherapy and occupational therapy, I have taken for all the programs which is approved and released by the National Commission. What is the pattern, name of the program, the pattern of delivery, the total hours of theory and practical, and then also the total credit. But when they calculated also, there are red point wherever I highlighted, there is an unequal distributions of the hours and the credit. That normalization also needs to be done. For example, if you see anatomy of physiotherapy, occupational therapy, theory hours is 180. So it is become a 12 credit, because 12 credit is even if you take 15 hours into 1 credit, it becomes a 12 credits. The practical component is 4 credit, because here the practical is, it is not exposing to the clinical. They are either in the dissection hall or in the preclinical lab, the training is given. So that usually we call it as the practical hours. When you say that when the student goes to the clinical posting, the 1 credit is equal to 45 hours. Clear? This is the another important point all of us needs to remember. For example, if you are in physiotherapy, a course of exercise therapy, student is practicing on the stretching after the teaching, that is called the practical. That 1 credit is equal to 30 hours. But if you are sending the students to the clinical for the observation, the 45 hours of exposure is equal to the 1 credit. So this is the way the normalization of the credit also needs to be done. This recommendation from the State Commission we have also given to the National Commission, so that when it is updated in the curriculum, they in principle they agreed that these normalizations will be done. This is the challenge. I think most of the institutions and the programs are facing this. We have gone through each program, how exactly we can, without deviating from the recommended curriculum of the National Commission, how we can normalize it. When you look at in the red point, the anesthesia and operation theatre technology, or in the physician assistant, you look at that, they have given 6.7 or 1.3, that may not be very appropriate. We have to normalize to a proper thing. You can't give 1.2 credit or 1.3 credit and all. Somewhere the department needs to work on that, how the normalizations can be done. This is about one example related to the various programs, the number of hours required, and then the credit of that particular thing. And also annual and the semester wise. Semester 1, in many of the program, anatomy is there only in the 1 semester. Whereas in PA or in the radiotherapy or in the nutrition and in the laboratory science and all, it is semester 2 also there in few of things. So that if you are conducting how an examination of that, if you are, for example, if you are combining optometry, AOTT, HIM, MIRT, PA together, ensure that in the first year curriculum, the lesson or the unit plan can be delivered. Even the PA student can appear for that thing in the first semester. Suppose if they have a second semester additional thing that can only be delivered to the physician associate program, they can appear for the examinations in the second semester. So this is the way the flexibility is given to the university. This most importantly here, I think Dr. Praveen is there, especially from the Rajiv Gandhi University. Praveen sir is here or left? Oh, yes. This can be proposed in the RGHS Board of Studies, so that because the number of colleges comes under the RGHS is maximum in Karnataka, so that normalizations can be done for all the institutions, so that the examinations also can be conducted in a similar fashion. Okay, the next important thing is with respect to the distributions of the marks. Anatomy, we have theory, as I said, the 20 for, and practical also internal assessment is given 20 marks. So in a year, if you conduct 3 internal assessment, then the 20% of that only is counted for the internal evaluations. The remaining is for the university paper. There are one clause is, I think we have already suggested, the combined passing is usually it needs to be recommended, because students ideally, if they are failed in theory, sometimes we ask them to repeat theory and practical. That may not be from the student's point of view. We are unnecessarily that we are disturbing them. Whether theory, the failed subject only needs to be repeated. This is the another important recommendation given to the commission. We will be waiting for their further communications also. Where exactly you can, example, if you take renal replacement therapy and dialysis technology, the internal is also given at the 50 marks, whereas the university paper is 100 marks paper, and then 150 is there, whereas the combining practical IA and then the university examination, it becomes a 100 marks paper. Whereas in radiotherapy or nutrition and all, the mark distribution is not given. So this we have to think, whoever the head of the departments are here, we need your recommendations, because there is absolutely how, whether it needs to be evaluated at the university or it is at an internal assessment, that clarity is not given. So this is about the one particular subject, how we can normalize. The same way this method can be used for all other common subject like physiology or biochemistry. Similar thing can be shared. We will through the Yenepoya University with Sunita Madam, we will share this if required to all the heads of the institutions. You can take this as a base and then accordingly you can prepare this. Then the other physiology, similar thing, I will not repeat that considering the time constraint. Biochemistry also. Then pharmacology, in some year it is first year pharmacology, in some programs second year pharmacology, how to normalize also, that can be done. Then maybe I'll directly go with some of the common subjects like psychology, each program wise it is there. English, this is recommended in most of the subject. It is actually, we can conduct it as an internal assessment, because when the eligibility is given 10+2 with the medium of instruction is English, this is one of the requirements for the higher educations, or when the students go to abroad, they usually look at the language proficiency, whether the medium of instruction is English or not. Because this is the one challenges in most of the time, people have been asked to write the TOEFL or the IELTS. This exam, language proficiency examination is conducted by the respective country. This communication skill and the English can actually consider as a non-university paper, not necessary to be conducted by at the university examination. So that with that internal assessment, the institutions or the university can conduct and then it can be incorporated in the marks card. The similar way, the basic science of computer and IT. This also comes under the ICT. So communication, now most of the digitalization or the digital technology play an important role in almost all the healthcare profession education. Therefore, the basic knowledge of computer is very, very essential. Even though the student may undergo training with other centers and all, but it is not reflected in their marks card. In this case, this can also be taken as a non-university paper rather than conducting the university paper. So that in every semester, at least one or two course or the subject you are reducing for the university paper. So this can be considered as a non-university paper. The similar way, introductions to healthcare delivery. But in HIM, this may be a very important thing. In other program, it is the student needs to understand the basic model of the healthcare system. So we can think about whether this needs to be, whereas in HIM this may be an important thing, may be recommended as a university paper. In other cases, whether to go with the university or even it can be conducted as a non-university paper. Like, environmental science and Indian Constitution, this is the mandatory requirement by the UGC. All higher education program compulsorily need to have the Indian constitutions and the environmental science. Therefore, this can also be, now it's already implemented in most of the university. Usually we conduct it as a internal assessment or the non-university paper. Okay. Then the professional values, it is important that, okay. This can be medical terminology and record. This is for HIM, this is an important thing. For other programs, you can think whether it needs to be as a university paper or the non-university paper, because already they have undergone detailed anatomy, physiology, biochemistry. Again, medical terminology, some may be case in subsequent semester, they will anyway learn the AOTT, will understand the various surgical procedure, various medical procedures, everything is studied in the further thing. Whereas in HIM, they may not directly go into the particular clinical subject. This, other than the HIM, you can think about this can also be as a non-university paper. Okay. Medical law, it's important thing, yes. Okay. Mathematics is only for the few. It is, I think it's an important subject for the optometry and the radiotherapy. Okay. So now the simple thing is, I think Dr. Sentila mentioned this point. When you have this, everything don't, the faculty not necessary to be loaded. Remember this point. It's as we said in the beginning, it's a student-centric learning, not teacher-centric learning. So that keep the student as an equal partner in your training program. So that any of the teaching classes, lecture, tutorial component can be included, self-directed learning can be included, demonstrations can be included, small group discussions can be included. So it is the responsibility of the faculty how you can make that particular unit, how many credit, how that can be distributed into the different segment. That is, it is the individual faculty can plan properly and then you can deliver. I'll just give one example, like in physiology of pain. I'm just giving one example for your reference. If there is a 1 credit of paper, physiology of pain, so which all the course outcome will be reflecting on that? It is starting with the C1, C2, C3 and C4. Because the students' definition is required. How we can divide that in 1 credit equal to, total hours is 15 hours. In that, 9 hours of teaching if you give, 6 hours can be self-directed learning and the tutorial can be included in that. So not necessary that entire 15 hours needs to be taught by the faculty. This is depends upon what is, you are the right person to judge. Because for example, when you say in physiotherapy, pain is an important aspect the student needs to know from the day 1 to till they come out as a graduate, because their management will be predominantly focused on the pain aspect. So in that cases, theory lecture, the sessions can be given little equal importance. For example, if we are taking other subject, it may not be directly linked to their clinical practice. In those cases, the theory hours of teaching can be reduced, the student directed learning or the tutorial can be given the little bit more weightage. That is at the discretion of the individual heads of the department or the faculty can plan this way of method of delivery. Okay, so this has been already highlighted. Suppose if the practical component is there, any one of this can also be included in your evaluation. Not necessary that everything needs to be demonstrated by the teacher. So initially we need to teach and then give more scope to the students to practice. This can be assessed by the skill component can be assessed by the faculty member. So this is the very quick overview or the summary of the first year. The consolidated, which all the course or the subjects are there in each program. How we can consolidate depends upon the number of hours. When you are running a multiple programs, how you can bring all these programs together and what should be a simple delivery method. Rather than taking every load by the teacher, a student-centered learning, how we can bring the student as a part of our training. So with this I will conclude. Thank you all just. If you have any question, any 1 or 2 specific questions we can ask. If any
Any questions? Any clarifications required?
This particular PPT we will share with all of you because this is a consolidated one, and we have also made the Word document of that.
So first I thank you very much. You have elaborately briefed out what we want to do. In case of that 6 hours self-directed learning and tutorial, how we can have the assessment?
Self-directed learning is given the assignment, or you can include in the micro-teaching. These are the different method you can use for because the students' involvement is more. Actually, even in the credit calculated by the either European or the US is giving, for example, if 1 hour of teaching, they give 3 hours of student directed learning, 1:3 ratio. Whereas in European model, it is 1:2. So the equal number of hours of engagement needs to be given to the student. Even if you look at our national credit framework policy, they are also suggesting the similar way. Keep all these things, not just only by the teaching by the teacher, equal participation from the student is important. Any method, assignment, micro teaching, it depends upon the which unit you are selecting. If there is a skill component is more, give more importance to the practical or the skill assessment component. If it is a knowledge oriented thing, assignment or micro teaching, this type of things can be given to the students.
So this include even tutorial also?
Yeah, tutorial also. Yes.
Thank you, sir.
Thank you.
We have one more question.
Yeah. First of all, thank you so much, sir. Once again, I'm attending your class. Sir, I wanted to know, in certain categories like ISO, they have their micro lesson plan, and within 45 minutes, we have to have a particular number of topics. And if you see in Rajiv Gandhi University, they cram up a lot of topics just to complete in that 45 minutes. How's the practicality of us actually implementing with our Gen Z population? So that becomes a little, dicey to fulfill. Otherwise, we end up having to deviate more than 2 to 3 hours.
Actually, when you look at, if since you mentioned the ISO,
yeah.
ISO will not dictate any process to us.
Mm-hmm.
The process is defined by us. They will vet it and endorse it.
Yeah.
They are not asking us to do like this. Whatever process if I defined, then they will ensure that whether you have followed that process or not. So the similar way you have to like when I think course outcome, when it is discussed, we have to prioritize which particular subject is more important to that particular program. In example, like in physiotherapy, when you teach anatomy, if you give 45 hours of teaching to the gastrointestinal system, tomorrow student is not going to practice that at all. Okay. So that redistribution, it is the responsibility of the faculty needs to be done. Whereas they have given a lot of importance to the central nervous systems or the cardiovascular systems, musculoskeletal systems, where their skill is very, very important when they are coming out as a graduate. So where to normalize the hours, that we have to take the responsibility.
That's theory. And when we're doing the continuous assessment, the internal assessments that we actually give on the process of it until we reach the summative, how do we decide what percentage we would give for the internal assessment?
If you are including the continuing assessment aspect, you define, for example, as I said, this pain hours I have given, 3 hours. Ask the student to do the small group discussion, micro teaching. 2 or 3 students, you have to give the topic, they have to prepare and then present. So that way the students' involvement will be more. The practical component or the clinical component focus more on the case discussions. Including their assessment hours, everything needs to be included in that.
Thank you so much.
Okay. Yeah, we have one more question.
Good afternoon, sir. My name is Seema. I am the principal of Sridevi College of Allied Health Sciences. Yes, sir, with regard to the curricular pattern, what you explained, I have 2 queries, sir. So you said many of the courses, for example, you gave anatomy is common in the first semester, but the units what are there, the chapters what are there varies from the program to the program. And you said it has to be rectified. So Who is going to do it and what is the thing? I wanted to know.
The deviation, if you very closely, if you look at in the each curriculum, maybe a 20 to 30% deviation is there. You can say that about 60 to 70% there is a common pattern is there. That is the responsibility of the faculty in charge to look at those common subject, you can bring together and you can deliver in common classroom. The remaining 30 or 40% have to be taken separately.
Yes, sir. That is with regard to classroom teaching.
Yeah.
No, you said the question paper pattern can be common for those particular
When you
programs.
conduct in the first semester, if you, for example, I gave an example of PA versus other thing. There are only few programs have in the first semester itself. So when you are combining all these things, there will be common classes and the common question paper will be set to them. And in the second semester, only the other department or the program, they have a separate additional anatomy or physiology subjects are there that can be taught separately, that can be conducted in the second semester.
So my doubt was regarding the university set question paper. So you said 20 to 30% there will be a deviation. So suppose for all those courses in the first semester, if they have a common question paper and maybe one or two courses out of that, the programs, they do not have those chapters in the syllabus, then that will be a...
That you are anyway, if it is second semester, if they have those individual programs, additional subject, you will be taking in the subsequent semester, no? There is no overlapping of that.
The university question paper.
University question paper, that is the responsible, that's what I said, the Board of Studies. Board of Studies is the important member to verify all these things and ensure that every institution of that university will deliver in the similar fashion.
Oh yes, okay sir.
Yeah, that is the most important thing. This needs to be discussed in the board.
Board of Studies.
Yeah,
okay, yeah.
That's why I asked where is Dr. Praveen, because he is looking after the Rajiv Gandhi universities. I think Vasantan, Dr. Praveen and other members are there. There in the Board of Studies, all of you are the member. There you have to sit together and then normalize and then deliver.
So even the credit also, some discrepancies are there.
That can be normalized.
In the Board of Studies.
Yes.
Thank you, sir.
Thanks.
Thank you, sir, for this wonderful session with a lot of questions and thought-provoking for everyone. We'll take a short break for lunch.
Okay, thank you all. Thanks.
There's a small announcement. Lunch is served at our university canteen Raintree. So our faculty volunteers will direct you to the venue of the lunch. And post-lunch, please be back by 2:30 for the next session. Thank you.
Good afternoon, everyone. Moving to the next session, I welcome Ms. Anjali Kotian, Assistant Professor in the Unit of Respiratory Therapy at Yenepoya School of Allied Health Sciences, who contributes to curriculum development and continues her clinical involvement in pediatric and neonatal ICUs. Alongside academic, she serves as a Coursera admin at Yenepoya School of Allied Health Sciences, where she facilitates online learning opportunities. She is also the treasurer of Indian Association of Respiratory Care. I welcome ma'am to take over the session.
Good afternoon all. First of all, I would like to thank the Karnataka State of Allied Health Council for giving me this opportunity to express my views and give a talk about such a critical topic, that is designing competency-based assessment. Now, I know the post-lunch inertia is going to kick in. We are going to get little maybe drowsy and everything. I'll try my best to make this an interactive session and definitely try to catch your attention, yes? So, education in allied health has come a long way now. From the traditional way of teaching and learning, we have come to something known as competency-based education. So as teachers, as educators, what is our role here? Definitely a very big role in terms of implementing it, in terms of making sure that our colleagues, our junior faculties, and even students understand what is this competency-based education, because at the end of the day, they are the ones that we are targeting. For them, we are doing all this implementation and changes, right? So my learning objectives would very briefly go through drafting a competency statement and looking at the assessment tools. In the morning session, sirs and madam, they have very clearly defined as the program outcomes, program specific outcomes, course outcomes, learning outcomes. How are we going to implement this? Where are we going to implement this? Dr. Senthil Kumaran sir has also very beautifully explained us the different assessment methods, right? Now what are the tools that we use for these assessment methods? That is what I will be taking care of. So I know we have been talking about competency. What is competency? I will not go ahead and ask or tell you what is competency. Just one thing, please take out your mobile phones, quickly scan the QR code given there and put in your thoughts of what you think is competency.
Yes. Just to make it little more interactive, can I please request you all to scan this QR code and share your thoughts about what is this competency? You can put in your thoughts, you can put it in one word, a sentence, however you like it, but please share. Yes, proficiency, okay, great. Ability to perform, amazing. Standard quality, definitely it gives us a standard quality. Skill, very rightly told. Efficient, knowledge plus skill plus attitude, absolutely correct. Ability to meet the demands of a situation, relevant to current situation, experience, efficiency, expertise. We see what all of us are thinking about competency, and ultimately we are coming up with the cloud of our own thoughts, isn't it? Now, when very beautifully our earlier speakers had explained to us what competency is, one thing everybody has highlighted is knowledge plus skill plus attitude. At the end of the day, it gives us something known as competency. So here I think I will move on to the next slide so that we don't have to waste much of our time, but definitely thank you all for your responses.
And like you all very rightly have mentioned in that, competency is definitely knowledge plus skill plus attitude. And what are we at the end of this day saying? We are giving a statement. We are putting forward a statement that the student, for example, has to perform safe endotracheal suctioning using aseptic technique in a simulated setting. So that is how we came up with a competency statement. What I will do in my session is take you through how we come up with this competency statement. So what are the types of competencies that we are looking at? In a very nutshell, I have put it: the core clinical skills, procedural skills, communication skills, and the clinical reasoning skills. I know you all might agree with me that these are the core competencies that we are looking at for our students to develop. Isn't it? Yes? Please give me a yes. Okay, I know I might be little tortureful. Immediately after lunch I'm giving and coming and giving a talk, but please bear with me. Maybe at the end of this session you will take away a few points from me. So how do we draft a competency statement? Is it as simple as putting out a statement there? No, it is not very simple. We have to be very clear. We have to be very precise. So what are the characteristics of a good competency statement? This is where I tell you we have to be smart. As teachers, we are very smart. Yes? Yes? So how can we be smart? Is this. Initially, first step is to be specific. The first step is to be specific, that is, define a very clear action. Now what is the action we are telling there? The student will perform closed suctioning on an intubated mannequin while maintaining full sterile technique and achieving less than 10% drop in saturation. Very clearly we have defined our statement. It is not very vague, student will do suctioning. No, we are very clear how the suctioning should be done, in which patient it will be done, what should be the environment where the suctioning has to be done. All of this is defined. That is our first step to smartness, that is S, be specific. Next is it should be measurable. We have to give it as an observable evidence. Like an example, if it is a MLT student, we say the student will analyze a peripheral blood smear and correctly identify all three elements: RBC, WBC, platelets. We are very clear what we are measuring there. We want the student to identify RBC, WBC and platelets. Yes? Coming to A, achievable. It should be achievable. It should be appropriate to the learner level. You cannot give PG level competencies to an undergraduate student. You have to identify, is this particular student able to achieve this competency? Yes, then definitely put it there. Please make it into a statement. But if it is not, that is where we play a role. We have to identify which student or which level of learner is going to able to complete this competency. Relevant, it should be linked to our curriculum. It should not be something out of the curriculum, right? So it has to be definitely be a part of the curriculum. For example, the student will assess a trauma patient using the primary survey A, B, C, D, E to ensure rapid identification of life-threatening skills. I have to make sure my students learn about trauma survey and only then go ahead and put this as a competency statement. Otherwise, what will happen is my student might not have acquired the knowledge for the same, but I am expecting the student to have skill or the skills to be demonstrated for this, which is absolutely wrong. So that is our next step, or it should be relevant. And last but not the least, completing our smartness is T, time bound, that is under defined condition. We have to define in how much time or in how many weeks the student should be able to acquire this skill. So for example, the student will arrange major OT instruments in correct sequence for laparotomy within 10 minutes. I am giving there a specific timeline. Within 10 minutes you have to do this. What it teaches the student? It teaches the student the urgency. When one case starts, the next case is about to be started. How you can do the time management. So that is why I say we have to be smart when we are going to draft a particular competency statement. These were the examples that I gave. Now, just to look at the structure of this competency statement, I have something known as an ABCD model. In our childhood, ABCD simply meant apple, A for apple, B for ball, C for cat. Now we come for A for audience, for whom definitely what all of us are looking at. So an example could be a student will be able to perform venipuncture on a patient simulator following standard infection control procedures without causing contamination or harm. Here we go slightly higher on the level. We want the student to perform the action without causing any harm. So you see how we are defining each of the criteria here. Going towards the affective domain, that is the attitude and behavior, I want the student to be able to demonstrate empathy and effective communication with patients during venipuncture as observed by the instructor. So what you can see in all these three examples is we are being very clear what the student should do, how the student should do, and to what extent the student should be able to perform the task, isn't it? Now, I have just put up two statements here. Please try and look at the statements on your left and on your right and let me know which do you think is a bad competency statement and which is a good drafted competency statement. The one on the left or one on the right? The one on the right is good. Can I please have a show of hands? One on the right is good. Who says one on the right is good? So the statement I would read for you, the one on the left reads, the student should be able to assist patients in performing chest physiotherapy techniques and support them during the session. This is statement 1. Statement 2 is, the student will be able to measure and record blood pressure accurately using a sphygmomanometer on a patient following infection control protocols without errors. So can I please have a show of hands whether the left statement is better or right? Who says it is right? Right. Okay, we have few hands for right. Who says the left statement is better? We have few. Okay, so I would reveal which one is the wrong statement here. Might not be wrong, but poorly drafted competency statement is this one, the one on your left. So that is where you see it is not defined properly. The student doesn't know how long the session is going to be. Student doesn't know whether there are any level that the student has to achieve and in what way the student has to do the chest physiotherapy. Student is not knowing. What it will do is, it will end up giving you inaccurate results and then you might give less marks to the student. Is that right? Definitely not. Why? Because of a student has to score low marks? Definitely no. So that is where we come with better statements. We give good statements that are specific, observable, measurable, and they include context. We have to give a context. Bad statements are vague, non-measurable or inappropriate verbs will be used, and in any statement, it doesn't have to be only cognitive. I will check only cognitive. I will check only psychomotor. I will check only affective. No. Your one competency statement can involve all the domains. Right? So we have looked at how to draft the competency statements. I have few more, places where I have put up quizzes and also that we can have some interactiveness. So that is why I am moving ahead. Now, we have looked at the competency statements and everything. Why the assessment matters? Because traditional assessment, they only looked at the memory. They only test the memory of the student. But we have come far ahead of that and we want to actually see the performance of the student. And what are we doing? Competency-based assessment will ensure transparency, consistency and fairness in evaluation. This is where competency-based assessment comes. Now when I say assessment, if you remember from the morning session, sir very beautifully explained us the different methods of assessment. Direct observation or OSCE, OSPE, setting up mini clinical exercise, and so many methods are there, logbook or even making portfolios. There are so many methods to do the assessment. But can we do this assessment without any tools? Can we do this OSCE, OSPE without any tools? We need to prepare the tools for this. And that is what we are going to look at, how to develop this assessment tools. So I have a roadmap kind of that will help us take you through what should be the steps when you are actually developing the assessment tools. So the first one would go like initial competencies. First, you have to define what is the competency. You have to make sure the core competencies for that particular program are identified, be it medical laboratory technology, anesthesia and operation theatre technology. We have to make sure initially, that is the first thing, we have to define the competency. And second, we would go with defining the learning outcomes. We want the learning outcomes in place so that we can go ahead with the next step, that is develop an assessment blueprint. We should know what level of assessment we are going to do. Which domains are we going to address? Are we addressing the cognitive domain? Are we addressing the psychomotor domain? Are we addressing the affective domain? Or are we addressing all the three domains? How we are going to assess them, right? And then the next step would be select the assessment format. In what format or in what method you are going to assess this particular student. Next, coming to creating the performance criteria. How are you going to create the performance criteria? What skill you want the student to show you there, or what do you want to see the student is doing there? This we can do with the help of rubrics and checklists. I will be coming to that. And last but not the least, giving the scoring tools. So that is where your rubrics come into picture. I have to put one thing here. We can do any kind of assessment, but as long as we do not design these assessments appropriately, it is a waste of our time, isn't it? Yes, if we have not designed, if we have not given proper scoring, what will happen is there is confusion for the student, there is confusion for the assessor, and there is confusion for the person who is keeping all this in check. So rather, we can reduce all these complications by simply going in a step-by-step approach, and that brings me to this one particular rubric that I am going to put in front of you. Please look at this rubric carefully and tell me what is wrong here. We are giving 4 marks for a student who introduced themselves to the patient, and then we are giving 3 marks for pre-procedure preparation, 2 marks for patient positioning. This is a rubric for ABG sampling and analysis. Yes, this is a rubric for ABG sampling and analysis. Just for introducing to the patient, the student is going to get 4 marks. Is that correct? Definitely not. Then, Just for the safety and infection control, they are getting 4 marks. Somewhere for blood collection, such a big task, student is going to prick the patient, is going to draw blood, we are only giving 1 mark. Is that correct? No. This is where blueprinting comes. That means how much weightage we are giving to one particular criteria that we have set in the rubric. So we have to be very clear on what domain gets how much of weightage, and it can vary from program to program. It can vary for medical laboratory technology, it can vary for AOT program, it is going to vary program to program, and that is where we as teachers come into picture, where we sit with our department, we define these competencies, we define these outcomes, and we define which domain gets how much of a percentage. So always before an exam, a formative exam, any kind of formative exam, we should make sure we sit with our colleagues and decide what domain gets how much of percentage. Like for example here, I have put up 3 the domains of learning: psychomotor, cognitive and affective, and I have put the skill ABG sampling, ABG interpretation and communication. ABG sampling through OSCE method, the weightage is 20%. ABG interpretation, that is through Viva method, it will carry 20% weightage, and affective domain, that will assess the communication skills of the patient, will be done with a holistic rubric, and that carries 10%. So you can see how we have divided the rubric into various percentages, and this makes sure that just for smaller task, talking to the patient, introducing to the patient, you don't give too much of marks. You will not be able to assess your student adequately that time. So this brings me to the performance criteria. How do we define this performance criteria and what it is? So when I talk about performance criteria, it is about what the learner must demonstrate. When we are assessing the student, we want the student to do certain tasks that we are expecting out of the student. So it should definitely tell what the learner should demonstrate, at what standard, to what extent the student should perform a particular task, and under what condition. All of these things come under your performance criteria, which is shown here by the help of a checklist where I have put up the steps, procedure steps. This is for suctioning in a mechanically ventilated patient, and I have put yes or no. Isn't it? Yes. So what the evaluator is now going to think, the assessor is going to think, if the student identifies the need for suctioning, okay, I will give a yes. But have we defined it adequately there? On how the student is going to assess. Maybe the student understood that the patient needs suctioning, but maybe the student did not go and confirm with the physician that can I do suctioning? Is suctioning actually required? Right? We have not defined all this. That is where I bring for you designing the rubrics. Yes, designing rubrics is very, very important. We might have a performance criteria in picture. We might have certain criteria in our head that the student should do so and so task. But how well do we put it up in a rubric? How well are we going to assess it? That is where designing an adequate rubric comes into the picture. And when I say rubric, there are so many types: holistic, analytic, developmental rubric. What goes into allied healthcare education is mainly holistic and analytic rubric that we look at. So what is this rubric? Rubrics are nothing but they increase the reliability by describing the levels of performance. That means whatever the student is doing, very easily, in a very criteria defined manner, we can assess the student. To what level? Is the student competent? Has the student done it in a well-mannered way? Has the student, or does the student need any improvement there, or absolutely bad performance? We can define all these levels with the help of a rubric. And then it helps us to break the task into steps and define the performance levels, for which I have a quick rubric here that
tells the steps for in an anesthesia and OT technology, preparation of the patient, technique, looking at the patient's safety and comfort, following the aseptic practice, and the post-procedure care. I have all the levels, all the criterias that I want my student to follow, and at the same time, I have the scoring there. If the student is missing any equipment or sets up the OT in a poor way, then 1 mark. If partially prepared and needs reminder, did you check this? Did you check for that equipment? Then the student is in the developing stage. Adequately prepared, basic setup is correct. Competent, we can say competent. I know it is slightly stronger word, but here in terms of rubrics, we can define in our own way what words we choose for which kind of level. Fully prepared, organized and efficient. Then we say proficient, we can give 4 marks. Excellent preparation, anticipates all needs, doesn't need any reminders. Even before you ask, the student has kept it ready. The student thought, what if any complications arise, I will keep the equipment for that also ready. That is what we say anticipates the needs. And there you can give 5 marks, that is exemplary performance. So in a similar way, all the criteria can be defined, and rather than going for lesser point scales, that is 2 point or 3 point, it is better to go for 5 point scales or higher, which gives you a clear idea whether the student is in a very poor place, in a satisfactory place, needs improvement. What these rubrics are telling us, these are basically feedbacks for us, right? Yes? Yes or no? Rubrics are a way to give us a feedback or an understanding about the student's performance. Can we share the rubrics with students? Yes? We have to share. One thing that I don't know many of us don't follow is we do not share the rubrics with students. We don't tell them this is on what basis we are going to assess you. We should share the rubric so that the student knows, okay, if I do the certain task in this manner, I get this marks. That means I can master the skill that I am learning here. Very quickly, going through the analytic rubric. An analytic rubric is something that evaluates specific competency separately. So like in the previous rubric we saw, I had asked whether the student is positioning the patient, preparing for the event, or checking for the post-procedure care. I am defining the criteria there. When we use that kind of approach to prepare a rubric, we call it as an analytic rubric. And what this rubric allows us, it helps us to identify the strength and weakness. That is what I told you, when we use a 5-point scale or a higher, maybe 10-point scale, it gives you a very clear-cut picture where your student stands, how much improvement is required, isn't it? So example of analytic rubric would be again where we have very clearly defined the criteria. This is for checking the blood pressure measurement, so preparation, cuff placement, technique, reading accuracy, communication. These are just 1-point definitions that I have put there, and further it has been defined in terms of the criteria for 1 point, 2 point, 3 point, 4 point, 5 point. And at the end of the day, what we get is, we get a score for the student definitely, but we also get an idea which particular step did the student miss. So I can reinforce that step in that student. I can identify the particular criteria where the student is missing, or I can identify where the student has done amazing, excellent job, isn't it? So that is what analytic rubric tells you about. Holistic rubric is another thing where you are given an overall competency idea. So this is a very quick approach, very simpler rubric I will say, but we are not defining the criteria here as such. You get an idea of the assessment as a whole. So like I said, quick overall assessment, and it is useful for us. Why? As assessors, we don't have time. We don't have time to evaluate 100 students, 150 students. It makes it easy. But is holistic rubric the right way to go for many course clinical skills that we are looking at? Definitely not. That is where choosing the right rubric also matters. What kind of rubric you use for what kind of skill is very, very important. And this is a very small example of holistic rubric. I am just saying 5-point exemplary,
performs BP recording with exceptional accuracy, smooth technique, correct cuff placement and excellent communication. In a very limited manner I have put the idea, okay, the student has done cuff measurement, blood pressure is measured, accurate, this thing is there. But are we able to identify, did the student follow all the steps? Did the student there communicate to the patient that I am going to come and place the cuff on you? Did the student do it in the right manner? These things we don't know in holistic rubric. That is where the analytic rubric and holistic rubric are going to be different. So another thing is checklist. My favorite thing is checklist. Check, check, check everything. Even if I am doing a particular task, I will check everything. Okay, this is done, this is done, this is done. Checklist is another thing that helps us a lot when we are doing OSCE and OSPEs, rubrics, checklist, all of these are going to help us a lot. And how do we prepare a good checklist? Is basically by looking at if it is having a distinct type of rubric or not. Checklist itself is a rubric actually, but here you are going to get an idea of every decision being binary. It will be either a yes or no, present or absent, pass or fail. Yes? So just quickly looking at this is where again example of the student measuring blood pressure in a patient, and then I have put yes or no. Greets and explains procedure to the patient, yes, no, I have defined. Selects appropriate cuff size, yes, no. I have all the steps there and I just have a yes or no. At the end of the day you get certain points, 1 point for all the yes, and negative marking we don't usually follow, 0 marks for whatever step is missed. This checklist also helps us to understand what critical step the student has missed or what critical step the student has performed. Checklist will help us to give an idea to the assessor on clearly the assessor knows, okay, even if this student comes, some other student comes, I don't have to be worried. What if they are taught in a different way? What if they do things in a different way? At the end of the day, I want the student to greet and explain the procedure to the patient. Yes, done. Okay, I'll give the mark. I want the student to select the appropriate cuff size. Done. I will give the mark. So it makes the work of the assessor or the evaluator very easy, where we have clearly defined this is what student should do, and based on this the student is going to get marks. So just again a quick activity. I have put up checklist A and checklist B. In A, we are looking at patient ID, hand hygiene. This is for venipuncture. Both the checklists are for, rubrics are for venipuncture. Rubric A and rubric B. Look at the scoring, look at the criteria defined there. In both places I have given same criteria. Patient ID and consent, patient ID and consent, hand hygiene and PP, hand hygiene and PP. Please tell me and look at this carefully and tell me which is better. So for your answers, everybody has seen the rubric? Yes? Okay. So sorry, there is a technical glitch. Yes. Can you all please scan the QR code? Can you all please quickly scan the QR code, and the question will pop up on your screen and you can remember which rubric, A or B, which was better. So the question is, you looked at the two rubrics on the screen, which one do you think is better for assessing venipuncture skills? There was rubric A and there was rubric B. Can you all please select the appropriate answer as per you? Okay, we are at 90%, 10%. Okay, great. Yes, most of them think rubric A was better, and very rightly rubric A was better. Why? Because it was more defined. It had all the criteria very well defined, and we could identify there if the student is doing a particular task correctly or not. Whereas in rubric B, what was the problem? I had put the criteria and I said give marks between 1 to 10. How many marks? based on the assessor is going to be confused. Should I give 1 mark? Should I give 2 mark? Is this student better than the last one? There is no clarity there. That is where we are going wrong. Now, can you please quickly tell me? Okay, so we have Premanand sir and Shiva, Anaga, Shraddha, all of them have given quickest answers. I will try and see if we can give chocolates to you as a motivation purpose. Thank you so much for giving the answers. Congratulations. And very quickly, we will go at another QR code. This is the last, I promise. This is the last QR code you will be scanning today. And please tell me in one word or a phrase, how could we improve these rubrics for assessing the clinical skills? We saw the bad rubric. Can you please tell me how we can make it better, how we can improve it? You can type in whatever thoughts you feel about it. With explanation, okay, great. Smart rubrics, very good. We can follow the smart approach. Have to be more specific and clear cut. Specification, absolutely. So the bigger word is what most of you all are responding with. Task to be relevant, clear component. Okay, so one word that we can see in this word cloud is specification. Very rightly understood. In rubric, we have to be very specific. What we want the student to do. We have to very specifically put up the task that this is what you are supposed to do. It is easy for the student. It is easy for the assessor as well on how to assess. So thank you for responding. I would quickly go for the next slide. Now, what is this? What are we looking at? Something that we all have seen, done, been a part of, doing for this students. What is it? Anybody, any answers? OSCE, OSPE, great, amazing. So it is definitely OSCE and OSPE, that is Objective Structured Clinical Examination and Objective Structured Practical Examination. Or assessment, we say. This is definitely a very good method to assess our skills or the core skills that we look for in students. Now what is this? It is a very systematic approach that will focus on the skills. We have been doing this for so many years, just that now we are highlighting it, isn't it? I have attended OSCE and OSPE as a student, now I am doing it as a teacher as well. So what is this OSCE and OSPE? What is the whole thing? That is where this Miller's pyramid comes into the picture. We know the levels of Miller's pyramid: knows how, shows and does. What OSCE does is, it sees how the student shows. The shows, that is demonstrates, performs. That is what we are going to evaluate with the help of OSCE or OSPE. Very quickly going through what are the particular steps that you want to look at. You have to give one explicit competency per station. Every station should not have 2 or 3 competencies clubbed. It can have multiple domains being assessed in one station, but not 2 or 3 competencies at once. It should be time bound. One station should not take 10-15 minutes. We don't have whole day to keep assessing our students. So you can limit it to 5 to 7 minutes. Even better, research shows 2 to 3 minutes is also well enough for a student to answer a particular station. Then checklist, very, very important. Checklist should be aligned with the performance criteria. We have looked at how we make checklist. We have also looked at how to define the performance criteria. So this is going to be a very important tool for conducting OSCE and OSPE. Standardized patient instruction. If there is a patient involved who is going to mimic for the student for the examination, we have to give clear instructions to the patient. It shouldn't be like, I am patient A, I have to mimic patient B with tuberculosis. Student comes and examines, student interviews me, do you have tuberculosis? I say no. Are you coughing? I say no. What is happening here? The patient who is supposed to act out doesn't know why he is here or what he is supposed to answer there. You have not given a script. So we have to define all these things very clearly, and we have to design the OSCE or OSPE, whichever assessment we are doing, in a very structured manner, and clear pass or fail threshold. There is no gray in between. It is either black or white. Either the student passes or fails. So we have to be very clear with our scoring as well. So a quick tip for how to go through the OSCE and OSPE. We look at the channels, that means in what way or what are the stations. We have to define the stations. In one station, the student is going to interview the patient. In another station, maybe the student has reports of the patient and the student is going to interpret the reports, maybe a arterial blood gas report, maybe a chest x-ray. In the upcoming station, maybe the student has some blood values that the student has to identify. All our stations should be very clear, and like I said, it should only look at one competency per station. And then the materials, whatever materials we need, we should be absolutely ready with that. Any artifacts, any bed, seats, reports, other items, whatever is required, we should be ready. It is not like, okay, just with the flow we will go. This is not how we make a structured OSCE exam. Not on the day of the exam I will run around searching for the reports and everything. We should plan it weeks before the exam happens. OSCE and OSPE are such assessments that should be planned weeks before they are done for the student, and the student should also get a training. This is the way we are going to assess you. This will be the exam. We are conducting an OSCE for you. There will be so many stations. You will be evaluated in each station. So the staff as well as the student needs to be trained on how the assessment will be done, and definitely the examiner sheet. Most important thing. So what is this evaluation examination sheet? So your evaluator or your assessor is going to depend on you. What checklist you give them, what rubric you give them, based on that they are going to assess the student and give them a pass or fail, right? So we have example here. Procedure is measuring of radial pulse rate. Station 2, title is measuring of the radial pulse rate. Instruction is observe. This is instruction to the evaluator. Observe if the student is performing the following steps correctly. Score 1 for each point performed correctly, or mark 0 if the task is incorrectly done. Let us look at the rubric that we have given, or the checklist. So you can see here a sample OSCE OSPE checklist where we have put up the step, what the student has to do. Every step contains 1 mark or 2 mark depending on the weightage. So informing the client about the procedure, 1 mark. Check the patient's arm is resting comfortably, 2 marks. Locate the radial pulse, 2 marks. What you also see here is the marks is allotted appropriately. Just for greeting the patient, the student does not get 2 or 4 marks. Student gets 1 mark. Very basic skill from the affective domain. And then how check the patient's arm is resting properly. All of these steps are going to be defined, and the evaluator has a clear-cut idea. Okay, student greeted, student explained the procedure, I will give 1 mark. Did not do, I will give 0 mark. It is as simple as that. So to come to a conclusion or to summarize, what are the best practices for drafting these competencies or doing this competency-based assessment? Align the assessment to real-world practice. It should not be just something that I am imagining. It should be actually happening. The students will tomorrow go and work as healthcare professionals in hospital. So it should definitely be real-world related. Use multiple methods. Not only OSCE, not only OSPE. You can go with the checklist and rubrics and everything. Provide feedback early. Like sir was telling earlier, Dr. Senthil sir, formative assessment is the way to go. So during this formative assessment, we are going to quickly identify, and then we are going to tell the students, this is the step you are lacking at, you can improve here. And conduct calibration meetings for the examiners as well as students. So both of them should be aware of how your assessment is being done, what the rubric is, what the checklist is. Please share it with your students so that they have a better idea how I can go about with that, and make rubrics transparent to students. We don't have to hide it from our students, we have to share it with our students so that they know what they are supposed to learn and how far competent they should be. And I would like to conclude with, competency-based assessments are not actually complicated, just that they are systematic. We have to go in a structured way to do this competency-based assessments for a student, and I hope I was helpful enough to give you maybe some takeaway points, and that is all from my end. Thank you.
Thank you, ma'am, for having such an interactive session and delivering valuable information on designing competency-based assessment. Moving on to the next session.
I am honored to introduce Dr. Praveen Aaron, an eminent academician in the field of physiotherapy. Sir currently serves as the professor and principal of Padma Shri Institute of Physiotherapy, Bangalore, and is the president of Autonomous Board for Assessment and Rating under the Karnataka State Allied and Healthcare Council. With over 2 decades of experience in academia and research, he has significantly contributed to the curriculum development, professional training, and evidence-based physiotherapy practice. His dedication to the academic excellence and professional advancement has earned him several prestigious awards and recognitions. Please join me in welcoming Dr. Praveen Aaron. Over to you, sir.
Good afternoon, everyone. Thank you for those kind words of introduction. And as all of you gathered here, some of you might have been a part of the first implementation strategy meeting that we have had in Bangalore in MS Ramaya on the 29th of September. And following that, it was decided that we will be conducting from the council side, as a part of the duty of the council based on the direction from the National Commission, that we would be doing a zone-wise implementation strategy workshops to help and ensure all the institutions are almost able to fulfill the expected requirements and outcomes from the directives of the Commission. And so, once again, good afternoon to all of you. And welcome to this session on implementation of curriculum. This is a follow-up to our previous workshop which we have had in Bangalore, as I mentioned, and today's session we will be reviewing the major outcomes and questions that emerged in our previous sessions, and then we will be moving forward to establishing a clear, actionable institutional roadmap for implementing the NCAHP curriculum, which is expected to get implemented as a mandate from the year 2026 admission batch. And so the aim is to move from planning and discussion into structured execution strategies, and that is what we have been doing since morning here, so that all the institutions can actually adopt them uniformly. And this has been the intention, and we've been moving with this particular strategy. So the purpose of this session, in this session actually we will focus on 4 key objectives. First, we will revisit what was achieved in the previous workshop. Second, we will look at the main concerns and gaps identified across institutions. Third, we will outline a phased implementation roadmap for each institution. And finally, we will set the stage for a smooth, coordinated transition towards the NCAHP 2026 curriculum rollout. So our purpose today is 3: clarity, direction, and practical steps. So let us briefly recall the major highlights of our previous sessions today. We introduced the principles of competency-based education, the shift from traditional content, heavy models to measurable skills and performance indicators. Then we discussed course outcomes, probably program outcomes and program specific outcomes, and how they link directly with our competencies. And we explored assessment tools, especially OSCE and OSPE, the one before, and essential for evaluating what we call as real world clinical experience or performance. And overall, I'm sure through the day, the different sessions you have been through have laid what we call as a conceptual foundation. And so today we will move towards implementation and systems level readiness, what I call it to be. Now, in our previous workshop and in the sessions that we have had across institutions which we met in Bangalore, several positive developments were reported. Many colleges, we realize, have begun aligning their curriculum with the NCAHP handbook, what was released 2025. And we also realize that if you understand what I mean by mapping, mapping has started for competencies and outcomes. We also realize that many of the assessment tools were well received, and most institutions showed a willingness to adapt OSCE-based or OSPE-based evaluations. But we also identified certain gaps. What we realized was that some institutions lack a fully updated board of study structure. We also realized that examination policies were not consistent across the universities. We also realized that many faculty members expressed the need for more orientation on competency-based education, CBE, and the National Credit Framework. I should tell you that these gaps are normal at this stage, so don't worry about it. And today we are going to focus on bridging them. So these were the most frequently raised concerns in the previous workshop in Bangalore. Institutions wanted clarity on promotion rules. Now, if you need to understand what I'm talking, I hope, and at least if not, please go through your category handbook. Only then probably you may realize what I'm talking about. So do not leave even a page or a line. I would request all of you, it's a humble request to please go through the curriculum handbook. If you have not done it, then many of us may not understand what we are trying to actually convey across to all of you. So institution wanted clarity on promotion rules, especially whether students with failures can proceed to higher semesters. Then questions actually came up about supplementary exam timelines and how credits versus marks should appear on the mark sheet. Then we have had concerns that about the faculty eligibility and guide student ratios also generated a lot of discussions, particularly in case of MPT and the Master of Physiotherapy program we have had and I'm sure probably there would have been concerns even with other categories or areas. And even in terms of infrastructure, several institutions asked about the hospital requirements, OPD facilities, and the specializations, the options for offering various specializations. When I say that, probably in the existing, if you are affiliated to Rajiv Gandhi University, there were a lot of specializations available. And when the NCAHP came down with its criteria, a lot of those specializations are not seen there. So these were some of the concerns that actually broke out at that point of time. And these queries, actually form the backbone of today's implementation roadmap. So we should ensure that all institutions move forward with a consistent interpretation, and that is the intention. Now, from the feedback that we received, these were the major implementation gaps that we came across. Some institutions actually lack a proper examination manual aligned to CBE, competency-based education. Then internal assessments are not fully connected to competency milestones or skill progression. That is what we realize. Probably when we look at our institution and the way we work, we are a kind of floating population, and so though many institutions offer what we call as teaching methodologies and workshops like that, we learn and we move out when we find a greener pasture, and the ones who joined would not have got the opportunity towards this. That's probably one of the reasons. But having said that, we need to actually look into how we need to get connected to competency milestones or skill progressions. And another most important thing is documentation, especially logbooks and mapping matrices. Now, Madam before was trying to insist the thing or convey across to all of you in a different ways of all these specifics. And most of these logbooks or mapping matrices, even if available, is incomplete or is inconsistent. So we need to take a closer look at these aspects. So the goal now is actually to ensure that these elements are standardized and strengthened so that the curriculum implementation is uniform and it is also what I call it to be audit ready. So from our discussions and planning, this is something which we have created like a roadmap divided into 4 realistic and achievable phases. Phase 1 is what we call as preparation phase, where we can form a curriculum implementation committee, identify the gaps, and completing full CO, PO or PSO mappings. This is what every university should do, or every institution under a specific university should initiate and proceed to. Phase 2 is what we call as a developmental phase, where institutions are expected to create lesson plans, course files, assessment rubrics, and the examination manual. Phase 3 is the pilot phase, where you or we must actually expect to conduct what we call as mock OSCEs or OSPEs, introducing competency logbooks, and conduct faculty development programs. And phase 4 should be the rollout phase, where we ensure complete compliance with the 2026 batch, supported by monitoring and reporting mechanisms. Now this has to be looked into very seriously, and this phased approach actually will ensure that institutions can progress systematically without any much overwhelm. Now, as I mentioned earlier, a major part of curriculum implementation actually relies on quality documentation, and this is a practice which we need to start cultivating and start doing. Institutions must maintain at least, I repeat, institutions must maintain at least competency mapping matrices, outcome alignment tables, clinical skills logbook, assessment blueprints, practical exam checklists, such as OSCE stations, OSPE stations, and an updated academic regulations manual. These must be kind of, the mandatory institutional documents which will serve as a proof of implementation during audit and council reviews. And this will also help ensure transparency and consistency in your education delivery. So, what are the roles of Karnataka State Allied and Healthcare Council and universities? KSAHC, we will help you to interpret the policy. We will help you to have faculty training and support. We will help you in implement monitoring. And universities, we request you to actually update BOS and curriculum structure. Ensure the curriculum structure reflects NCAHP requirements and standardize marks, credits, and examination procedures. And together, institutions, universities, and the council will form a triangular governance systems ensuring uniform curriculum and implementation across the state. This is what we are focusing and working on. So to conclude, we must realize that implementation is not merely about rearranging curriculum documents. It is about transforming how we teach, assess, and train our future professionals, ensuring competency, accountability, and quality. We are moving today with a roadmap, clarity, and a commitment to uniform standards statewide. So, I would like to conclude by saying thank you, and we now move to the next session, probably on program-wise implementation. Any queries?
Yeah, if anyone has any queries with regard that you have, yes, you went through all this, we had a session, now implementation, but if you have something, you are welcome to ask. We council members are here, so we can give the inputs. I think no queries, everybody's geared up.
Clear, okay.
Geared up to start. Implementation of competency-based education. Yes, yes, madam.
Ma'am, I'm from Dr. M. Shetty, Allied Health Science College. My name is Professor Shri Priya. My concern is, ma'am, regarding MLT syllabus, MLS syllabus. In the first semester, 7 subjects are there. And as sir said, we can combine, all those things are there. But in each, for example, MLS or MIT or ATOT, if we have to combine, the curriculum is planned in such a way that we cannot combine all the programs, ma'am. So the faculty ratio is 1:10. How we are going to maintain it or manage it?
Biggest challenge, I can see Professor Rajesh is smiling. See, I understand all of us. I think Dr. Arun Maya in his session told that you see all the your basic subjects like your pre and paraclinical and ad physio and such courses. I know all of the institutes, they had one common platform. We had all, even under Rajiv Gandhi, it may be in Yenepoya or it may be in Manipal, I'm sure. So we all had done that, the base was same. So resources were utilized in properly, I can say, otherwise it's very difficult for us to get teachers separately, resources, every 40 students we take class, another 30, it's very difficult.
Yes.
What we are looking at here is, at the BUS level, for you it is Rajiv Gandhi, even there the work is going on, because as a BUS member, sir was also their last discussion, we're all working there as well. So you come across and sit across and see what is best possible that you can combine. Right, that's the way forward. Otherwise, to get so many faculty members, conduct different class for 15 You have 10 people in, say, in anesthesia ward, another 15 in MLT, another, you cannot have, it's very, very difficult. You as a team, you sit, see how it is, give your inputs to your board of studies. So that's where sir said curriculum committee. Within your institute have a curriculum committee. Go through it and see what best is possible. You know as a subject expert what it is required for your program, right? And see. And the best way to do is must know, good to know and desirable to know. Put the must know into one category and that can be for a cross. Right? Somewhere in some, say which is good to know for RDT course or desirable to know if I go some about RDT course. It may not be required for MLT. For them it is a desirable to know. It may be a must know for this. Right? That exercise we have to do. It is a work, I understand, but that is a requirement at present. So anything, Rajeshwari sir?
I have to say, you already said it. Basically, the problem is, as I have told earlier, all this syllabus which has been prepared are by consultants. There are committees and there are subject experts, faculties across the country who are given the input. But they are all worked in silos. They are not worked together. So they are putting across the regulations wherever the institutions are together, how to work it out. So the modalities and regulations will be released very soon. So please wait for it.
Ma'am, one more concern is, maybe I'm wrong, but my concern is, as in the curriculum it's mentioned, NEET is mandatory, that is appearance for the eligibility. Appearance for the NEET examination.
It's not NEET pass, it is a
appearance.
Appearance, yes.
Sir,
what is the problem?
Problem is, no, my concern, just for the clarification. Allied Health Science is a course where all filtered out students will come. They will not opt for it. So NEET exam, how many students will take to just to come for the Allied Health
That is
Science?
your job to create awareness amongst the students. Who are your prospective candidates who will be joining you? See, ultimately everybody will start. One day you have to make some start. So we are doing it now. Earlier MBBS also it was the same case. They made NEET, they made CET. Everybody started participating in it. When you tell there are no seats available without this, everybody will join. They are not told you have to pass NEET. So please understand, they want to bring in a culture which is good for your profession. We should be accepting it. Only thing is, it is your job to create awareness. So please do that.
In fact, it also makes a lot of eligibility procedures more smooth and with a clear track. Because many times we have situations where, the first eligibility check happens when the student actually applies for NEET as an eligibility requirement. So that even helps actually. Second thing, you had already answered your question by telling filtered out. So that means they have already appeared for NEET, most of them. So I think it actually resolves there, and it's a good, I think we need to take it as a positive step where actually a lot of professions get recognized at a par level. So it is important.
Thank you, sir. Thank you.
Sir, Arun Mayas, sir was telling that in the university level they can synchronize the curriculum so that the common subject will not be a difficulty when they are implementing at the college level. Like for example, let us say anatomy, physiotherapy, occupational therapy has different hours, but there are other courses like allied. So they have semester system. So if the semester system which is having only 6 months, and there are other courses which has 6 months as well as the second semester also. So what he suggested is, you suggest to your university so that whatever curriculum is required for the first semester and whoever are falling in that category, let it be that, and for second semester let it be the additional things. So by those also, that will make easier for the other people like college level, synchronizing the students, attending the classes, appearing for exam, preparing for that,
Yeah.
that will be more easier.
Yeah, that is what we
That
had.
is what ma'am was asking, that I think that
Yeah,
could
that
be
is-
one way how we can make it.
No, that is the what we discussed. I think she also got the point, because it is you in the your college as a curriculum committee, you look at it and then give the, because if you are attached to Rajiv Gandhi University, your recommendation should go to the Rajiv Gandhi
Board of
University
Studies.
Board of Studies.
Yes, yes.
For us, for example, Yenepoya, we have our own Board of Study, we have a curriculum committee, so we will take it up. It's
Where study is
something.
there in Board of Studies. That's why we-
Yes, yes.
So that is what I actually mentioned in this particular slide. University's role is to update the BO's Board of Studies and curriculum structure and standardize the exam patterns and credits. So that's where it all goes into.
Any other? Otherwise, we will go to the wrap-up round, closing. Yes, please. This is the opportunity for you to have anything to be discussed. Please put forward your queries.
Good evening, sir. This is myself, Seema, from Sridevi College of Allied Health Sciences. Sir, I have a doubt regarding the end-term exams, that is end semester exams. Now, many of the engineering, or there are basic degree courses, universities affiliated to that, like example Mangalore University. They have odd semester and even semester exams. So how will be our pattern of examination? Will it be like only now, suppose this month you're conducting odd semester, first semester, second
I
month?
think your institute is attached to Rajiv Gandhi.
Rajiv Gandhi
They are
University.
taking up this. They are doing it wherever it is not there, because that was the discussion in the Board of Studies. I am also the member there, we're all there. So it was discussed, this was also discussed, and the recommendations are given odd, even, how it should be. So they are working on it. And the direction will come from there. Wherever this evaluation, assessment and these things are not clear, it will be done by the university. And they
Good evening, sir. So nice presentation. I am in RGHS Board of Studies for PG. So when we come to Board of Studies, they say that anyway you have a council which is coming up, you can follow the council's regulations. So regarding anything, say, as you said, where is the barrier where we need to stop? Like for example, curriculum structures.
Okay, now I think all of you, I get where you are having that question from. Thank you very much for opening it up once again. And what happens is, I think the Curriculum Development Director has already convened a meeting with the Board of Studies chairmans based on the meeting that you have had with regarding to the implementation of the handbook. Now that's a handbook, and then views or opinions were taken about various areas of concerns, and these views have been sent across to the commission. And I think both the councils, the state council and the university is actually waiting for a response from the professional council at the commission. So once the clarity comes, you will be intimated and all of you will have a clarity on the various aspects of concerns that was raised at that point of time. That's one thing. The other thing is, so it's not a barrier actually, because what we find is the commission has been entrusted by the government to actually release all the curriculums for the 10 categories and 10 curriculums, and they are actually in the process of it, because morning you would have actually realized from the various talks that it was, the commission was actually formed in 2021 and there has been a delay, and now the task has been given to actually roll out the things, and so they are actually in the process of rolling out various aspects of the categories of courses, and so definitely there is a delay, but we expect all this delay to be overcome probably in the coming days very soon. And when they say that they want to get it implemented from 2026, definitely they will come up with solutions to most of our queries, at least in the coming couple of months. And that is what we understand from, we have the member from the commission, Professor Rajesh Shenoy, and also our secretary to the DME and secretary for the council, director from the DME and secretary to the council. So both of them have been attending those meetings on a regular basis, and that's the feedback that we have received. I hope I've answered the question. Thank you. Thank you all.
Thank you, sir, for an insightful and comprehensive session. As we come to the concluding segment of today's program, it is my privilege to invite a highly respected academician and administrator, Dr. Srinivas Murthy, Deputy Director at the Directorate of Medical Education. Sir is an accomplished clinician, educator and policymaker whose contributions have significantly strengthened the dental education and public health care in Karnataka. Sir also serves as the Secretary of the Karnataka State Allied and Healthcare Council. Please join me in welcoming Dr. Srinivas Murthy to deliver the closing remarks. Over to you, sir.
Thank you. Sorry, as you raised the question of BOS barrier, when the National Commission has issued the curriculum, you should be talking about implementation of that. There is no barriers as such. From next academic year 2026-27, it has to be implemented. So you should be discussing about how to implement it, how to follow the curriculum which has been issued by the Commission. That's it, no? So it has been a privilege to conclude this enriching workshop on competency-based education in allied and healthcare professionals and implementation strategies, which is held at Yenepoya, deemed to be University today, in collaboration with our Karnataka State Allied and Healthcare Council. For the past sessions, we have collectively deepened our understanding of the evolving educational landscape and the critical role of competency-driven training in shaping the next generation of allied health professionals. So actually our discussions began with comprehensive introduction to the principles and philosophy of competency-based education, emphasizing its learner-centered, outcomes-oriented and practice-grounded approach. We explored the framework of CBE, highlighting how clearly defined competencies, structured learning experiences and milestone-based progression form the backbone of this model. The sessions on evaluation and assessment in competency-based evaluation provided valuable insights into aligning assessment strategies with competencies, ensuring fairness, transparency and accountability. The workshop further guided participants through the process of designing competency-based assessment that are authentic, objective and reflective of real-world clinical and professional demands. A significant component of our deliberation focused on implementation of the curriculum issued by the National Commission for Allied and Healthcare Professions. We examined implementation strategies for preclinical education, discussed potential challenges, and shared practical solutions and institutional innovations. Through our collaborative dialogue, participants formulated institutional action plans to effectively integrate, operationalize the NCAHP curriculum within their respective programs. As we move forward, the Karnataka State Allied Health Care Council remains committed to supporting institutions across the state in this transition. We are pleased to announce a series of follow-up workshops that will be conducted across the Gulbarga, Hubli and Dharwad region, Davangere and Belgaum zones, enabling wider participation and deeper capacity building. We extend our sincere appreciation to the management of Yenepoya, deemed to be University, for their unwavering support and for providing an enabling environment that greatly contributed to the successful conduct of this workshop. And we also place on record our heartfelt gratitude to Dr. Sunita ma'am Dean of Yenepoya Allied and Healthcare Profession, whose guidance, coordination and provision of all necessary facilities with good lunch, which is very important to mention, ensure the smooth and effective organization of the program. Their commitment and their team commitment to academic excellence and professional development has been instrumental in making this workshop a meaningful and impactful experience for all participants. In closing, I extend heartfelt appreciation to all the participants who traveled all over the other places and gathered here, and facilitators and organizers for their active encouragement, engagement, thoughtful contributions and unwavering commitment to advancing allied and healthcare education. Let us carry forward the momentum generated here, working collectively to build a robust, competency-driven educational ecosystem that meets the evolving needs of healthcare society. Thank you, and we look forward to meet again at the upcoming zonal workshop. Thank you once again. And a big round of applause to the management who has provided all the facilities. Because this profession, the council has initiated, Karnataka State Council has initiated recently in the last year. It requires a lot of workshop of this kind, lot of discussions, a lot of educational workshops or conferences to make the participant understand the importance of implementing this curriculum which has been issued by the National Commission. I thank you one and all for your participation and wish you good luck in future endeavor. Thank you.
Thank you so much, sir. We'll be displaying the QR code. I request everyone to kindly scan the QR code and provide the feedback for the overall session today, for the workshop. Certificates will be issued once you all provide us the feedback.
thank you everyone. We have the tea served outside, so I request everyone to have tea. And the delegates going to Mangalore, we have our Yenepoya bus. So I request you all to take the bus at 4:30.